Hello. Hello. Good evening, everyone. So nice to see you all again. Yes, beta. Actually, I have provided the PDF. मैंने PDF just after the session I have provided to PrepLadder. हाँ, I know. I'm really sorry for that. That Dr. Sudhanshu, I know the PDF probably they are uploading. So my part was over yesterday. I provided to the team. Probably they are making some changes, and I just talked to them, the PrepLadder team. They assured me that they are in process, and within few hours the PDF will be uploaded on PrepLadder app. Okay. So don't worry about PDF. I have shared the PDF yesterday only, and it will be very soon provided to you. Don't worry. Don't worry. I'll take care. Okay. Sure. I hope you enjoyed the yesterday session. Today's session will be even more intense, beta, and I'll make sure that I will not leave anything. Even if I have to sit for long hours also, I'll completely finish the pharmacology. Yes, beta, if you are attending this session, FMG student also, I would say that NEET question and FMG question nowadays, they are almost similar. So if you have already attended the previous session of FMG, that's well and good. But if you will attend today's session, it will help you to revise the concepts again. And if you will revise again this volatile subject like pharmacology, it needs repetitive revisions. Okay. Yes, for INI-CET, don't worry, beta. There are few new additions which I will be telling you in this session. Okay. So this is mainly for NEET PG. Okay. This is mainly for NEET PG. And 95% of the questions of INI-CET will be covered in this also. Just 5% new monoclonal antibody or new anti-cancer drugs I will be taking separately, especially for INI-CET. Okay. So, okay, I'll try to speak in English. Don't worry, don't worry. If you're not comfortable with Hindi, I'll speak in English. So let's, without wasting any more time, your time is very precious. I respect that. Let's start with now the next part of last resort revision. So we are discussing part 2, and we will start with kidney and cardiovascular system. So in kidney, first we will discuss about diuretics. Any student who can answer this question, it was asked last year in NEET PG exam. Which of the following diuretic is matched correctly with its primary site of action on this nephron? So osmotic diuretic, they act on distal convoluted tubule, false. Thiazide diuretics, they act on proximal convoluted tubule, false. Carbonic anhydrase inhibitor, they act on is proximal PCT, true, and potassium sparing diuretic, they act on collecting duct, true. So our answer will be B. Beta B. B will be the correct answer. Don't worry. Let's discuss all diuretic at one place. So the first class of diuretic we have is the first class of diuretic we are having is carbonic anhydrase inhibitor. And all carbonic anhydrase inhibitor, they will end with the word zolamide or amide. You can see zolamide or amide word will come in there. Sir, why they are ending with the word zolamide or amide? Because they are derivative of one antibiotic sulfonamide. And any drug which is sulfonamide derivative is contraindicated in sulfa allergy. Now, what is their primary site of action? We will mark this point. They act on PCT of nephron. So they act on PCT, proximal convoluted tubules of nephron. And don't worry, beta, we are taking MCQ. And after solving an MCQ, we are discussing topics also. That will help you better, I believe. Straight away MCQ will not help you. So what are the uses of acetazolamide-like drug? Mnemonic is GAME. So they are used in glaucoma, as we discussed yesterday. Remember, they are given for alkalinization of urine. Now, they are the drug of choice for mountain sickness. So we discussed it yesterday. Drug of choice for mountain sickness is acetazolamide. And they are also given sometimes in the treatment of epilepsy. Now, if you talk about their side effect, we can remember a mnemonic base. The only diuretic which can lead to bone marrow suppression is acetazolamide. Why? Because of sulfa allergy. They can increase ammonia levels in the blood. That is why they are contraindicated in a patient of liver disease, because ammonia will not be converted into urea, and ammonia can damage brain, encephalopathy can happen, and they can cause stones in kidney. They can cause kidney stones, basically calcium phosphate stones. Now, any diuretic which is given for the treatment of calcium stone, yes, acetazolamide causes calcium phosphate stone. For the treatment of calcium stone, we give another diuretic, that is thiazide diuretic. Agreed? Now, osmotic diuretic, we have a very important drug, mannitol. It is given IV, 20% solution, and it acts on the next part of the nephron, that is loop of Henle. So it acts on loop of Henle. Now remember, mannitol being an osmotic diuretic, it will increase plasma osmolarity. And if plasma osmolarity is increased, CSF production will fall. And if CSF production will fall, intracranial pressure will fall, ICP will fall. Similarly, aqueous production in eye will also fall. That is why intraocular pressure will also fall. That is why mannitol, remember, that is why mannitol, it is the drug of choice for which edema in brain? It is the drug of choice for cerebral edema, and it is also given, yesterday we discussed, in glaucoma also. Now remember, there is a technique when we do dialysis of a person. Remember, when there is a dialysis we are doing in a person, filtering of blood, it can lead to decrease in osmolarity of plasma. So plasma osmolarity decreases when we do dialysis, and decrease in plasma osmolarity can lead to cerebral edema. That is why, to maintain plasma osmolarity and to prevent cerebral edema during dialysis, this condition is known as dialysis disequilibrium. The drug of choice is mannitol. So mannitol is given in dialysis disequilibrium. Last year NEET PG question. Now mannitol, remember, excrete all metals in urine. So first metal is lithium in chemistry. Second metal is platinum, cisplatin, anti-cancer drug. So it is given in the treatment of lithium toxicity and cisplatin toxicity. But remember, the follow-up question is, which diuretic is absolutely contraindicated in CHF, chronic heart failure or heart failure? Which diuretic is contraindicated? That is mannitol. Mannitol is also contraindicated in kidney failure because it increases plasma osmolarity. It will put more pressure on the heart. The patient heart will die. Next diuretic beta we have is loop diuretic. Now loop diuretic, they act on this part of the nephron, which you call it as medullary portion of thick ascending limb. On medullary portion of thick ascending limb, there is a transporter known as sodium potassium 2 chloride transporter. This transporter is inhibited by loop diuretic. They inhibit sodium potassium 2 chloride transporter. The first diuretic among loop we made was mercury containing. The drug was Marsalil. Nowadays we don't use because we all know that mercury in poisoning, it damages ear, it is highly ototoxic. So nowadays we use sulfa containing furosemide, torsemide, bumetanide. Bumetanide most potent, torsemide longest acting drug, and among all diuretic, high ceiling loop diuretics are the most effective diuretic. They are the most effective diuretic. Most effective diuretic are known as high ceiling diuretics. Agreed? Now, then we have a diuretic, that is thiazide. Thiazide will act on next part of the nephron, that is DCT, distal convoluted tubule, and they inhibit one transporter known as sodium chloride symporter. They inhibit which transporter in DCT? Sodium chloride symporter. So in thiazide diuretic names you have to remember, it's very important. So we have some drug which are thiazide. They will have thiazide word in them, like chlorothiazide, hydrochlorothiazide, and we have thiazide like, we can remember a mnemonic CMI. CMI is क्लोरथैलिडोन थैली वाला ड्रग, मिटालोजोन मेटल वाला ड्रग, इंडपामाइड इंडिया वाला ड्रग। तो थैली, मेटल और इंडिया, ये तीन वर्ड हमें याद रखने हैं। एंड रिमेंबर मिटालोजोन, इट इज द ओनली ड्रग अमंग थायजाइड विच इज सेफ इन रीनल फेलियर। कौन सा थायजाइड सेफ है रीनल फेलियर में? लो जीएफआर कंडीशंस में, दैट इज मेटल वाला मिटालोजोन, वेरी कॉमनली आस्क्ड एमसीक्यू। नाउ रिमेंबर, loop and thiazide diuretic, they have same side effect. Remember, loop and thiazide diuretic, they lose all ions in urine except calcium. So they can cause hyponatremia, they can cause hypokalemia, and they can cause hypomagnesemia. Agreed? Do you agree with this point? That is why loop diuretic, it is the drug of choice for the treatment of hyperkalemia, hypercalcemia, and hypermagnesemia. Now there is a difference between loop and thiazide, and that difference is related to calcium. Remember, except calcium, loop loses calcium in urine. Thiazide retain calcium. T word is coming in blood. That is why loop diuretic in blood, they produce hypocalcemia, while thiazide diuretic in blood, they will lead to hypercalcemia. Keeping this thing in mind, loop diuretic are given in the treatment of hypercalcemia, while thiazide diuretic, they are given in the treatment of hypercalciuria. Understood the word? Hypercalciuria? Fine? Just a moment. Found anything for that. Hypercalciuria, remember, if excessive calcium is excreted in urine, it can lead to calcium containing renal stone. That is why thiazide diuretics are given in the treatment of calcium containing renal stone. Next diuretic we have is potassium sparing diuretic. They will act at the last portion of collecting duct in nephron, that is collecting duct. So they will act at collecting duct and they inhibit the action of one hormone known as aldosterone hormone. And these are the only diuretic which side effect is hyperkalemia. Rest all other diuretic, they produce hypokalemia. So that is why they have the name potassium sparing diuretic. So we have two types of drug, one which will directly go and block aldosterone receptor, and second we have drug ENaC inhibitor, epithelial sodium channel inhibitor. This is a protein which is produced by aldosterone hormone which reabsorbs sodium. So we have four drugs, SEAT, S-E-A-T, SEAT. So spironolactone, eplerenone. So they are aldosterone receptor antagonist. Amiloride and triamterene, they are ENaC inhibitors. Now remember, these are the only diuretic which will act from basolateral side of nephron. पीछे से काम करेंगे नेफ्रॉन के, बाकी सारे डायूरेटिक ल्यूमिनल साइड से काम करते हैं, फिल्टर होते हैं, जहां से यूरिन जा रहा होता है वहां से काम करते हैं. नाउ व्हाट इज द एक्टिव फॉर्म ऑफ स्पाइरोनोलेक्टोन? ऑनवर्ड इसमें भी आएगा कैनरीनॉन. नाउ रिमेंबर, स्पाइरोनोलेक्टोन आल्सो ब्लॉक टेस्टोस्टेरोन रिसेप्टर. एल्डोस्टेरोन को तो ब्लॉक करता ही है, स्पाइरोनोलेक्टोन आल्सो ब्लॉक टेस्टोस्टेरोन रिसेप्टर. सो विच डायूरेटिक कॉजेस गायनेकोमेस्टिया इन मेल्स? The answer is spironolactone. Now from spironolactone we have made a new drug. That new drug is finerenone. Finerenone, I will be telling you, it's a new drug asked in NEET exam, approved for the treatment of diabetic nephropathy. So which new drug has been approved for diabetic nephropathy? Finerenone. Now amiloride, you can see Li word is coming in amiloride. Amiloride is given in Liddle syndrome. It is also given in lithium toxicity. Another diuretic I am telling you, Li word is coming. Very good. So I will tell you the list of the drugs which will be given for, which will produce gynecomastia later on. Now let's talk about, this is an important slide. Diuretics are given in the treatment of edemas. So first, in heart failure we know there is pulmonary edema, and in renal failure there is periorbital edema. The drug of choice is loop diuretics. The drug of choice is loop diuretic. In liver failure we have ascites. The drug of choice is spironolactone. While in cerebral edema, there is increase in ICP, intracranial pressure, we give mannitol. Now the question comes very commonly, which diuretic is contraindicated in? Which diuretic is contraindicated in heart failure and renal failure? Mannitol. Which diuretic is contraindicated in liver disease? Acetazolamide, because it was increasing ammonia levels. So remember, this is the contraindications of these diuretic. Next question, let's solve this MCQ which was asked recently. Incorrect match. Now we know the answer of this question. Incorrect match according to the use. So spironolactone is given in ascites, absolutely right. I will be telling you thiazides, they are given in the treatment of nephrogenic diabetes insipidus, true. Loop diuretic, yes, they are the diuretic of choice in renal failure, but we know mannitol, it is absolutely contraindicated in heart failure. This is a very frequently asked question. Next, now let's talk about one hormone which acts on kidney, that is vasopressin hormone. Vasopressin hormone is also known as antidiuretic hormone. First, we have vasopressin agonist. So in vasopressin agonist, we have terlipressin. You can see T word is coming. So you'll write it is V1 agonist. It stimulates V1 receptor of vasopressin. Then we have desmopressin. Desmo का मतलब होता है दो. So it rather stimulates which receptor of vasopressin? V2 agonist. Now V1 receptor is present on blood vessel which produce vasoconstriction. That is why terlipressin is the drug of choice for bleeding esophageal varices. क्योंकि varices में बेटा क्या होता है? Varices में there is dilated veins in esophagus which we rupture. इसीलिए हम terlipressin देते हैं, vasoconstriction produce करता है. Any other drug which we can give? Yes, we can give octreotide. So two drugs which can be given for bleeding esophageal varices. Drug of choice is terlipressin. Second drug which we can give is octreotide. Now terlipressin is also the drug of choice for hepatorenal syndrome. Hepatorenal syndrome happens when there is end-stage liver disease. The blood supply to the kidney reduces and kidney becomes damaged due to liver failure. So when we give terlipressin, it will increase blood pressure in kidney. It will improve renal blood flow. Terlipressin can be given. Now what about desmopressin? Desmopressin is given in hemophilia A because the V2 receptor increase the production of clotting factor 8. Desmopressin is also the drug of choice for neurogenic diabetes insipidus. So neurogenic diabetes insipidus give desmopressin. Nephrogenic diabetes insipidus give thiazide diuretics. I hope I'm not very fast with you. Agreed? Because it's a very rapid revision. Okay. So I hope you all are comfortable with my speed and pace. Even if you miss something, you can watch the video again. Okay. Each and every point I'm speaking is a potential question. Now we have a drug, vasopressin antagonist. These drugs are known as Veptans. These drugs are given in the treatment of chronic SIADH. SIADH stands for syndrome of inappropriate ADH secretion. When there is excess of ADH, we give these drugs Veptans. But one antibiotic can be given, demeclocycline. Why we give this drug? Because demeclocycline blocks vasopressin receptor on kidney. It reduces the action of ADH hormone on kidney. But remember, if the patient is having acute SIADH, the symptom is hyponatremia. Acute SIADH is an emergency. Here the treatment is hypertonic saline. Here the treatment is hypertonic saline. These drugs are only given in chronic SIADH. Now remember, bedwetting in children, which is also known as nocturnal enuresis. A child requires treatment if the age of the child is more than 6 years, and the first treatment is training, not drugs. And in training, there is a very important method known as alarm method. There is an alarm when the child is about to pass out urine, alarm will ring and the child will wake up and the child will voluntarily go and pass out urine. But if training fails, then we start drugs. And there are 3 drugs which have been approved for nocturnal enuresis or bedwetting in children, that is DOI, D for desmopressin. Second is oxybutinin. And third drug is an antidepressant, imipramine. So imipramine is a tricyclic antidepressant. It relaxes bladder so that the child will not pass out urine. That's great. Now 58-year-old man was found to be have stage 2 hypertension ऐसे without any comorbidities, without any comorbidity. अगर कोई और disease नहीं है, if there is only hypertension without any comorbidity, let's call this hypertension as essential hypertension. Now which drug you will start? Anyone beta, what is the answer? Which drug you will start? All bang on, सब बहुत ही बढ़िया. The answer is you will start with thiazide diuretics. So what are the first line drug or drug of choice for essential hypertension? Remember, there are 3 first line drug for essential hypertension. That means there is no comorbidity. Only hypertension is there. The drugs are CAT. C for calcium channel blockers, DHP type. And these drugs, they will end with the word dipine. So can you tell me any famous drug? Amlodipine, nifedipine, clenidipine, very commonly used. Second, you can give ACE inhibitor. Instead of ACE inhibitor, you can give the brother of ACE inhibitor, ARB. So these drugs either end with the word pril or sartan. Which drug to be chosen? I will tell you shortly. And which diuretic is the drug of choice? You can start thiazide diuretic. So these are the 3 first line drug for essential hypertension. Now imagine you have started one drug, BP not controlled, you added second drug, BP still not controlled, finally you will add 3 drugs. If the BP is not controlled by 3 drug in combination, this hypertension is known as resistant hypertension. Resistant hypertension is BP not controlled by how many drugs? 3 drugs in combination. So which drug you will add? You will add the 4th drug, which is considered to be the drug of choice for resistant hypertension, either spironolactone or its brother eplerenone. They were aldosterone receptor blocker. But recently, a new update, few months back, a new drug got approved for resistant hypertension. Probably I have told you the name of this drug yesterday also. Try to tell me which class of drug I am talking about. Let me write the name. Aprocitentan. Can you tell me which drug I am talking about? Aprocitentan. So it's a new drug for resistant hypertension. Entan word is coming. Can you tell me its mechanism of action? Yesterday I have told you entan word is coming. Yes, FANS, absolutely great. Now let's talk about the choice of drug will change if the patient is having some hypertension with other disease or comorbidity. Very good, beta. So if the patient is having hypertension with CKD, chronic kidney disease, which has microalbuminuria, hypertension with diabetes, stroke, retinopathy and scleroderma, then we start a class of a drug, ACE inhibitor, as the first line drug. So all ACE inhibitor, they will end with the word pril, like lisinopril, captopril, ramipril, etc. But ACE inhibitor has a side effect. ACE inhibitors, they increase bradykinin level. And because of bradykinin, the patient can have dry cough, the patient can have allergic reaction, angioedema, swelling on face. So if the patient is having dry cough or angioedema due to pril drugs or ACE inhibitor, then instead of ACE inhibitor, we will start ARB. ARB drugs are sartan. Sartans. So you can start telmisartan, any other sartan you can start. Now hypertension with peripheral vascular disease. So let me write peripheral vascular disease as Raynaud's disease, renal artery stenosis. Then in that case, you will start calcium channel blocker DHP type. These drugs, they will end with our dipine, like amlodipine, clenidipine, etc. Now, if the patient is having hypertension with these heart disease, let's say stable angina, hypertrophic obstructive cardiomyopathy, aortic dissection, then we start a drug. Beta blockers will become the drug of choice. But beta, we discussed beta blockers, they end with the word lol, like atenolol, metoprolol. They are contraindicated in asthma. So the question which was asked previous year in NEET exam was, a patient is having hyperthyroidism, but the patient is asthmatic. Would you start beta blocker? No. In that case, if the patient is asthmatic, shift this beta blocker to calcium channel blockers like verapamil or diltiazem. So we will start this drug. These calcium channel blocker are known as non-DHP type. So dipines are known as DHP type. These drugs are known as non-DHP type. I hope you have understood the basic concept behind it. Now next question, a known patient of hypertensive patient came to emergency with the complaints of palpitation and shortness of breath. Her BP is 140 by 220 by 140. Remember, if the blood pressure is more than 180 by 120, this is known as hypertensive crisis. That means it is an emergency situation. So which of the following drugs should not be given in the treatment of this disease? The answer for this question is beta, mannitol. Should not be used. So mannitol is contraindicated in hypertension because it can lead to heart failure. So the answer is mannitol. So let's talk about management of hypertensive crisis. So if the BP is more than 180 by 120, we label the patient as hypertensive crisis. So let's say a patient came to OPD, BP is high, but right now there is no organ damage. If there is no organ damage, we call it as hypertensive urgency. But if end organ damage has occurred, let's say MI has occurred, stroke has occurred, aortic dissection has occurred. If end organ damage has occurred, then we call it as hypertensive emergency. The overall drug of choice for hypertensive urgency is clonidine. And if clonidine is not in the option, you can go with the option of labetalol. But what is the drug of choice now for hypertensive emergency? Here we give a drug nicardipine now as the drug of choice. Nicardipine has become the drug of choice, but let's write the complete list of the drugs which we can give in the treatment of hypertensive crisis. You can make a mnemonic. Now nobody can help finally. So we can give nicardipine. We can give nitroprusside. We can give clonidine. We can give one ACE inhibitor which can be given IV, enalaprilat. Enalaprilat we can give. We can also give nifedipine. We can give clevidipine. They are other calcium channel blocker. Then help for hydralazine. You can give ismolol or labetalol, which are beta blocker. We can also give loop diuretics. And we can give phentolamine. And lastly, we have a drug phenoldapam. Phenoldapam stimulate, dapam word is coming, it is dopamine 1 receptor agonist. Now remember one concept I am telling you. Loop diuretics are given for hypertensive crisis. They are not given for essential hypertension. So which drug is not given in essential hypertension? Thiazide diuretics are not given in essential hypertension. Sorry, they are not given in hypertensive crisis. So thiazides are given in essential hypertension, but they are not effective in hypertensive crisis. Okay. Now ARNI are not given. ARNI are given in heart failure, which I am going to tell you, don't worry. A patient presented with, we are discussing about ARNI shortly. So patient presented with exertional nocturnal dyspnea, fatigue, cardiomegaly, pedal edema, gallop rhythm. Yes, the patient is suffering from CHF, chronic heart failure. On auscultation, there were drills in both lungs because of pulmonary edema. Which of the following drug can be used to prevent the progression of the disease? So you have to protect heart, you have to give cardioprotective drug to prevent the progression of disease in CHF. So the question is, which of the following drug can be given? Remember, captopril is a cardioprotective drug, which I am going to tell you. Even carvedilol is a cardioprotective drug, and this question came last year. But nowadays, we don't use which ACE inhibitor? Which ACE inhibitor nowadays is out of use? That is, captopril is the only ACE inhibitor nowadays we don't use because of its side effects. So that is why the best answer will become one beta blocker, that is carvedilol. Okay. So let's talk about cardioprotective drugs in CHF. The mnemonic is SAHIBs. SAHIBs. Remember, digoxin is not cardioprotective. Digoxin is not cardioprotective. Remember, we will be discussing about digoxin. So Sahib, the first drug we have is sacubitril. Make a star. I will be telling you about sacubitril shortly. Then we have ACE inhibitor and ARB. They are considered to be the overall drug of choice for CHF. We can give aldosterone blocker like spironolactone. We can give hydralazine, ivabradine, I make a star, I will be telling you shortly. Beta blockers. Remember, only 4 beta blocker. This is a very, very important question. There are only 4 beta blocker which are cardioprotective. And those beta blocker are New Bombay Municipal Corporation. New Bombay Municipal Corporation, and for nebivolol, bisoprolol, metoprolol, and carvedilol. Remember, only 4 beta blocker can protect heart in CHF. So in CHF, only 4 beta blocker are given. Very good. Agreed. Now, lastly, a very important class of drug we have is SGLT2 inhibitor. These drugs, they end with the word gliflozin. And these drugs are also given in the treatment of diabetes mellitus, like canagliflozin, dapagliflozin, empagliflozin, or any drug that ends with the word gliflozin is a newly approved drug in heart failure, and this is a very, very important point for you. Now, which drugs are absolutely contraindicated? That is verapamil and diltiazem. Remember, verapamil and diltiazem, which are calcium channel blocker, they increase cardiac mortality. They are absolutely contraindicated in CHF. We never give verapamil and diltiazem. Now let's talk about, there is a class of drug known as natriuretic peptide. Remember, natriuretic peptide, they reduce preload and afterload. That is why they can protect heart, because they are vasodilator. So they reduce preload and afterload. So we have made a recombinant form of BNP, which stands for brain natriuretic peptide. That drug which is given in heart failure is nesiritide. So what is nesiritide? It is a recombinant or synthetic form of brain natriuretic peptide. Its action in heart failure is it reduces preload and afterload. Now remember, in our body also natriuretic peptides are produced, but these natriuretic peptides, they will go to the liver. When this natriuretic peptide, they go to the liver, there is an enzyme known as neprilysin enzyme. See the name neprilysin. Nepri means natriuretic peptide. Lysin means they will degrade this natriuretic peptide which is produced inside the body. This enzyme is also known as neutral endopeptidase enzyme, and that is why we have made a class of a drug that will inhibit this enzyme. Agreed? That will inhibit this enzyme. So the drug name is sacubitril. So the drug name is sacubitril. So what is sacubitril? Sacubitril is a NEP inhibitor or neprilysin inhibitor. It increases the amount of endogenous natriuretic peptide. This sacubitril is given in the treatment of CHF. It's a cardioprotective drug, and it is given along with the drug valsartan. It is also given in along with a combination with the drug valsartan, and this combination of sacubitril with valsartan is known as ARNI. Very logical name. AR means angiotensin receptor, N for neprilysin inhibitor. So valsartan inhibit angiotensin receptor AR, and sacubitril inhibit neprilysin enzyme. So this combination is known as ARNI, given in the treatment of CHF as a cardioprotective drug. Now let's talk about the most important drug for CHF, that is cardiac glycosides, and the drug we have is digitalis group of drug, which is obtained from a plant. The plant name is digitalis plant. Digitalis plant has pink to purple flower, and the flower shape is trumpet like. Trumpet matlab बाजे की तरह, सबका बजेगा बाजा है ना. Now, the drug which we obtain and available in the market is digoxin. So, digoxin is a positive inotropic drug. It increases cardiac output. That is why it is given in the treatment of CHF. Last stage of CHF is known as decompensated state, when there is decrease in cardiac output. Now the question arises, why? Because digoxin inhibit one transporter, sodium potassium ATPase, which produce inotropic effect. which increases cardiac output. Now, digoxin inhibit SA node and digoxin inhibit AV node. That is why it has negative chronotropic effect. That is why it has negative dromotropic effect. It decreases heart rate. So don't you think these are similar to vagus nerve? So these are vagomimetic effects of digoxin. Because digoxin inhibit SA node and AV node, it is given to control atrial arrhythmias. So it is given in the treatment of SVT like AF. Supraventricular tachycardia, like atrial flutter and fibrillation, we give digoxin for the treatment. Another use. Now, what is the main side effect of digoxin? The most common side effect of digoxin is nausea and vomiting. Now, digoxin in eyes causes yellow vision. Yellow vision beta is known as xanthopsia, and this is a very specific side effect of digoxin. Very specific side effect of digoxin, and digoxin blocks testosterone receptor, which can lead to gynecomastia, and the list of the drugs which can cause gynecomastia is given in front of you, DISCO, which you can see from the PDF later on. Agreed? Now, digoxin causes yellow vision. Which drug causes blue-green color blindness? Blue-green color blindness. The drug is sildenafil. Sildenafil causes blue-green color blindness. Viagra. So how we can remember? Remember, Viagra is known as blue pill. Its color is blue. It causes blue-green color blindness. Which anti-tubercular drug causes red-green color blindness? Ethambutol. So these color blindnesses you have to remember. Now digoxin, it is excreted in urine by a transporter known as P-glycoprotein. Now there is a drug which is a P-glycoprotein inducer. The drug is rifampicin. Can we say rifampicin reduce the effect of digoxin? Because digoxin will be excreted out in urine, and we have P-glycoprotein inhibitor. So try to remember a drug verapamil, and try to remember erythromycin and clarithromycin. Erythromycin, clarithromycin and verapamil, remember, they increase the toxicity of digoxin. Because digoxin will not be excreted out in urine, a recent question was clarithromycin causes digoxin toxicity. Now, digoxin is contraindicated in hypokalemia and hypomagnesemia. Digoxin is also contraindicated in Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. And digoxin is contraindicated in hypertrophic obstructive cardiomyopathy. Now, remember, loop diuretics and thiazides, they themselves cause hypokalemia and hypomagnesemia. That is why loop and thiazide, they increase digoxin toxicity. Now, what is the treatment of WPW syndrome? WPW syndrome, there is abnormal conductive pathway on the heart. So, radiofrequency ablation of abnormal pathway, which you call it as bundle of Kent, must be destroyed. But if you talk about what is the drug of choice for WPW syndrome, that depends upon if the patient is having previous MI or not. No MI, no previous MI. If the patient is having previous MI, in WPW syndrome, we give prokinamide. And if the patient is having no previous MI, in WPW syndrome, we give a drug flecainide. They are antiarrhythmic drug. Now, what is the treatment of HOCM, hypertrophic obstructive cardiomyopathy? The drug of choice is beta blockers. But there is a new drug recently got approved for HOCM. The drug name is mavacamten. Mavacamten is a myosin inhibitor which reduces the contractility of the heart. Because of this reason, slowly and slowly the hypertrophy of the heart reduces. Mavacamten. Now, which of the following drug is not used in heart failure? Now, I hope you can give me the answer of this question very easily. So, sacubitril, is it given in heart failure? Absolutely right. Metoprolol, beta blocker, yes, cardioprotective. Nasiritide, recombinant form of brain natriuretic peptide, given. So, remember the answer for this question is trimetazidine. Last year question, Trimetazidine is rather given in the treatment of angina, not in heart failure. So it is given in angina. So let's talk about drugs for angina. We have three first-line drug for angina, that is BCN. Beta blocker, calcium channel blocker, nitrate. Remember, beta blocker, they are the drug of choice for chronic, long-term treatment of stable angina. But beta blocker are contraindicated in vasospastic angina because they themselves can cause coronary vasospasm. Calcium channel blockers like amlodipine, nifedipine, they are the drug of choice for chronic vasospastic angina, which is also known as Prince metal angina. Then we have nitrates like GTN, glyceryl trinitrate, ISDN, isosorbide dinitrate, ISMN, isosorbide mononitrate. They are the drug of choice for acute attack of angina. They are the drug of choice for acute attack of angina. And what is their mechanism of action? Their main mechanism of action is nitrates, they are venodilators. Because they are venodilator, they reduce preload on the heart. That is why nitrates, they are given in acute attack of angina. The main side effect of nitrate is tolerance. With time, the effect of nitrate reduces. Nitrates, they show tolerance. Remember this part. Now, second line drug for angina, we can remember a mnemonic, no drift. No drift. So, N for Nicorandil, a very commonly asked question where Nicorandil is used. We can very well see CO word is coming, DIL word is coming. So COR and DIL word is coming. So can we write COR and DIL word is coming in Nicorandil? So Nicorandil is a coronary dilator. It is a coronary dilator. How it dilates coronary artery? It opens potassium channel. It is a potassium channel opener which dilates coronary artery. Then we have another drug, dipyridamole. Dipyridamole is banned. Which drug is banned for angina? Dipyridamole has been banned for angina because it causes coronary steal syndrome. It causes coronary steal syndrome. That is why it has been banned for angina. Which general anesthetic drug can cause coronary steal syndrome? Remember, isoflurane. Isoflurane is a general anesthetic drug which can lead to coronary steal syndrome. Then we have ranolazine. You can see Na word is coming. It blocks sodium channel. Ranolazine blocks sodium channel, but its side effect is it blocks potassium channel also. Blocking of potassium channel can lead to QT prolongation on heart. Then we have a drug ivabradine. Brady word is coming, so it causes bradycardia. How ivabradine causes bradycardia? By inhibiting SA node. How it inhibits SA node? They block special funny channels on SA node. It blocks special funny channels on SA node. And next drug we have is trimetazidine. Tri word is coming. You can write tri. Tri word is coming and meta word is coming. So you can remember triglycerides, which are also known as fatty acids. They are not broken down. How they are not broken down in heart? By inhibiting one enzyme, PFOX inhibitor. PFOX means partial fatty acid oxidation inhibitor. So can we say it will shift the metabolism? Metabolism of the heart will shift from fats to glucose. Now the heart will utilize glucose. This is the main mechanism of action of trimetazidine. So I hope you can easily identify with the name trimetazidine. So never combine which drugs among themselves. Remember, beta blockers are never combined with verapamil and diltiazem because both drugs, they act on heart. They can cause severe bradycardia and the patient can have sudden death. Patient can have sudden death. Similarly, nitrates, they are never combined with which drug? They are never combined with sildenafil and tadalafil. Sildenafil and tadalafil are never combined with nitrate because they can lead to severe hypotension. And because of severe hypotension, patient can have sudden death. Now remember, there must be a gap between nitrate and sildenafil. There should be a gap of 24 hours. And between nitrate and tadalafil, there should be a gap of T for tadalafil is coming. T for, you can remember, 3 days. So 3 days T for tadalafil, it is a longer acting drug. So the gap should be 3 days. Now, which of the following anti-arrhythmic drug, match the following anti-arrhythmic drug with their mechanism of action? So sodium channel blocker. Which drug is a sodium channel blocker? Quinidine. So 1 ka A. Potassium channel blocker. The answer is ibutyllide. 2 ka D. Then we have calcium channel blocker. Verapamil. 3 ka B. And which drug is a beta blocker? They will end with our LOL. We know ismolol is a beta blocker. 4 ka C. So you can find out which is the best answer. I think C is the correct answer. Agreed? That's great. So let's classify all anti-arrhythmic drug. Anti-arrhythmic drug, we follow a classification, William Vaughan Singh classification. According to them, anti-arrhythmic drug are of or 5 classes. Class 1 to 5. Let's focus on class 1 to 4 first. 1 to 4, we can remember a mnemonic SOBIPOCA. So we can pronounce it SOBIPOCA. So for sodium channel blocker, BE for beta blocker, PO for potassium channel blocker, and CA for calcium channel blocker. Remember, sodium channel blocker, which are class 1, they are further divided into 1A, 1B and 1C, depending upon what they will do with potassium. 1A, they will block potassium. 1B, they will open potassium. So remember, B block nahi karta, A wala block karta hai, and most of the 1C have no effect on potassium channel. Now all beta blocker are under which class? All beta blocker are under class 2 except one beta blocker, that is sotalol. कौन सा beta blocker class 2 में नहीं होता? That is sotalol. Sotalol is the only beta blocker which is under class 3 that has potassium channel blocking property. And lastly, we have calcium channel blocker. What are class 5 agent? Miscellaneous. Don't worry, I will be telling you a mnemonic ADAM. ADAM से एक mnemonic पढ़ेंगे miscellaneous drug में. Now, if you can focus on this list, there are 2 classes of drug which block potassium. So which antiarrhythmic drug block potassium? Class 1A and class 3. Remember, any drug which blocks potassium channel, it has a side effect of QT prolongation. So which antiarrhythmic drug themselves can cause QT prolongation? Class 1A and 3, and they can precipitate one arrhythmia known as torsades de pointes. So remember, class 1A and class 3 agent, they themselves can precipitate torsades de pointes. So we don't give these drugs in these arrhythmia. So let's talk about class 1A. In class 1A, mnemonic is Cupid. So which drugs we have? We have Cupid. So Cupid, we have quinidine. Remember, quinidine, it is metabolized by D. D matlab CYP2D6. Its most common side effect is diarrhea. So remember, D with quinidine. Prokinamide is a part of SHIP drugs. So SHIP drugs are sulfonamide, hydralazine, isoniazid and prokinamide, and all SHIP drugs, they produce a side effect of DLE, that is drug induced SLE. Now we have one B agent, mnemonic is leave PMT. So leave PMT. So lignocaine, phenytoin, mexiletine and tokenite. Try to remember lignocaine and mexiletine. Lignocaine is given in the treatment of ventricular fibrillation, but remember, now the drug of choice for ventricular fibrillation has become amiodarone because it is the most effective drug. Agreed? Now lignocaine, remember, it is given IV, and mexiletine is an oral prodrug of lignocaine. Mexiletine is an oral prodrug of lignocaine. Question comes, which antiarrhythmic drug is also given in the treatment of diabetic neuropathy? In diabetic neuropathy, we can give mexiletine as a new drug recently got approved. In 1C, remember famous Prime Minister. Famous Prime Minister, flecainide is the commonly asked question. Try to remember, it is under class C, and we have discussed flecainide is contraindicated in MI patient. We don't give flecainide drug if the patient is having previous heart disease. This point we discussed in WPW syndrome. So let's talk about what are the drugs we have in potassium channel blocker. So the mnemonic is DVAS. D for dofetilide, ibutyllide, vernaculant. Try to remember amiodarone and sotalol. So which beta blocker is under class 3, that is sotalol. So amiodarone, remember, it is the most effective antiarrhythmic drug, and it is now considered to be the drug of choice for ventricular fibrillation. It is also the longest acting antiarrhythmic drug also. So amiodarone, remember, question comes very, very frequently. So let's talk about side effect of amiodarone. Remember, in amiodarone, IOD word is coming. IOD means it contains iodine. How much iodine? 37%. Because of iodine, the first side effect is thyroid problem. It can cause hypothyroidism and hyperthyroidism. Maximum what is seen is hypothyroidism. That is why we made a drug, a modification of amiodarone, dronadarone. Here IOD word is not coming, no iodine. So that is why no thyroid problem. Dronadarone, no thyroid problem. Now the second side effect of amiodarone is clip, T-clip. It causes cornea verticillata. It deposits in cornea just like a tree. It is also known as vortex keratopathy. Vortex keratopathy, deposition of amiodarone on cornea. It can damage liver. It can lead to interstitial lung fibrosis. And the color of iodine, you know, is purple or blue. So it can lead to purple man syndrome, which is sometimes known as Smurf syndrome. Okay, which is also known as Smurf syndrome. Fine. Fine. I hope you are able to understand. Okay, all these are one-liners. Yes, purple or blue man. Now, class 5 agents, I have told you a mnemonic Adam. Atropine, it is the drug of choice for bradycardia. Agreed. Digoxin, I have told you, it is given in SVT if the patient is having CHF. Adenosine, remember, it is the drug of choice for adenosine. It is the drug of choice for acute attack of PSVT. PSVT stands for paroxysmal supraventricular tachyarrhythmia. The dose of adenosine is 6, 12, 12 milligram maximum. 3 injections we can give. So the total dose of adenosine will become 30 milligram. So the total dose of adenosine, we can give 3 injections, 6, 12 and 12. And the main side effect of adenosine is just like beta blocker, it can also cause asthma. It can also cause asthma. While magnesium sulfate, it is given for the treatment of torsades de pointes. So these points I have told you. Let's answer this question, which was last year asked. A patient presented with palpitation and ECG, the initial drug of choice is. So can you see this ECG? And can you identify which arrhythmia the patient is suffering from? Remember, this is QRS complex. And after QRS complex, any wave will come. It will always and always be T wave. This is the rule. So the patient is having absent P wave. Absent P wave. So absent P wave is a classical hallmark of PSVT. And the drug of choice for initial PSVT is acute attack of PSVT is adenosine. But what about maintenance? So maintenance in SVT, long-term maintenance, apart from adenosine, we can give 2 more drugs. Remember, A, B, C. 3 drugs can be given in SVT, A, B, C. We can give beta blocker for long-term maintenance, and we can give calcium channel blocker like verapamil and diltiazem. Remember, adenosine and beta blocker, they both are contraindicated in asthma. So question comes, calcium channel blocker are the drug of choice for SVT in asthmatic patient. So remember, calcium channel blocker will be the drug of choice in asthmatic patient. Now let's talk about, can you tell me this ECG? What is this ECG? So you can see many different types of QRS complex. All QRS complex are having different morphology. There is no single shape of QRS. So this arrhythmia is known as polymorphic ventricular tachycardia because of different morphologies of QRS complex. Polymorphic ventricular tachycardia, it is also known as torsades de pointes. It is also known as torsades de pointes. The drug of choice is magnesium sulfate. And remember, torsades de pointes, which drug is contraindicated? Amiodarone is contraindicated because amiodarone itself can cause torsades de pointes. It's a potassium channel blocker. That's great. Now let's talk about, we are done with kidney and CVS. Let's talk about blood. Which hypolipidemic drug reduces lipoprotein A levels? Lipoprotein A is a marker of basically atherosclerosis. The answer is one vitamin, that is niacin. Niacin can reduce lipoprotein A levels in the blood. So let's classify all hypolipidemic drugs at one place. The first class of drug we have is statins like atorvastatin, rosuvastatin. These drugs, their mechanism of action is they inhibit HMG OA reductase enzyme in liver. And among all drug, it decreases LDL maximum, and LDL contains cholesterol. So that is why the drug of choice for hypercholesteremia to reduce cholesterol level is statins. The main side effect of statins is myopathy. They damage muscle and rarely they can be hepatotoxic. Fine. Then we have next drug, raisins. Raisins, they are bile acid binders, and they will start with the word cholestyramine, cholestyramine, and because of this reason they also decrease LDL level but not maximum, but they are the drug of choice in pregnancy because statins are contraindicated in pregnancy. Then we have fibrates. Fibrates, they stimulate one receptor known as PPAR alpha agonist. So when they stimulate PPAR alpha agonist, there is increase in production of one enzyme known as lipoprotein lipase enzyme, and lipoprotein lipase decreases triglyceride maximum. And their main side effect is again myopathy and gallstones. Lastly, which vitamin is given as a hypolipidemic drug? That is niacin. So niacin or nicotinic acid. So niacin, remember, increases HDL level maximum. It also decreases lipoprotein A level maximum. So niacin, its main side effect is it causes flushing, and niacin can cause gout. It can cause gout. So which hypolipidemic drug can lead to increase in uric acid level in the blood? Uric acid level is increased by niacin. Very important. Good. So identify this drug. This was a previous year question. Identify the drug which is a PCSK9 inhibitor. So PCSK9 inhibitor, remember these drugs, they decrease LDL level and it lower cholesterol. I will be telling you the drug name is evolocumab. This is a very frequently asked question. Let me tell you new hypolipidemic drug. So the first new hypolipidemic drug is ezetimibe. Ezetimibe inhibit one transporter known as NPC1L1 transporter. And this transporter is present in GIT, so it decreases cholesterol absorption from GIT. It decreases cholesterol absorption from GIT. Now these drugs are very important. Evolocumab and alirocumab, they are PCSK9 inhibitor. Because they are PCSK9 inhibitor, they increase LDL receptors on liver. And as LDL receptors on the liver is increased, liver will remove LDL or cholesterol from the blood. So it decreases LDL in blood. That is why it decreases cholesterol level in the blood. Now, how to identify these two monoclonal antibody? You have to identify LOC word in them. आपने कौन सा word identify करना है बेटा? LOC word identify करना है. LO का मतलब lowering of cholesterol. So evolocumab में LOC word आ रहा है. एलिरोक्यूमैब में भी LOC वर्ड आ रहा है. तो रिमेंबर LOC वर्ड आएगा तो वो PCSK9 इनहिबिटर हैं. A new drug recently got approved was bempedoic acid. It inhibit ATP citrate lyase enzyme. Very unlikely this question will be asked, but it also decreases LDL levels. So this question was indirectly asked last year. Bempedoic acid, it was one of the incorrect option which was given in PCSK9 inhibitor. So try to remember PCSK9 inhibitor, very important. So which of the following antiplatelet drug is against GP2B3A? GP stand for glycoprotein 2B3A. The answer for this question is, anyone, what is the answer? Anyone, what is the answer? Very good, Dhanshri. Very good, Dhanushri. Very good. So very good if you are remembering this part. The answer is apiximab. So apiximab is the correct answer. Don't worry. Let me explain you all antiplatelet drug. Antiplatelet drug are given in the treatment of MI, stroke, ischemic stroke, and Berger's disease. And everywhere the drug of choice is aspirin. With aspirin, we add other antiplatelet drug. It becomes dual antiplatelet therapy. The next class of drug we have is ADP receptor blocker or P2Y12 blocker. These drugs, they will end with the word grel or grelor. तो हमें कौन सा वर्ड आइडेंटिफाई करना है? ग्रेल और ग्रिलॉर वर्ड आइडेंटिफाई करना है. तो रिमेंबर, ग्रेल और ग्रिलॉर वर्ड आइडेंटिफाई करना है. क्लोपिडोग्रेल, प्रासुग्रेल, टीकाग्रिलॉर, कैनग्रिलॉर. रिमेंबर, जितने भी ग्रेल वाले ड्रग्स हैं, दे आर प्रो ड्रग्स. प्रो ड्रग मतलब इनएक्टिव ड्रग. और जितने भी ग्रिलॉर वाले ड्रग हैं, दे आर एक्टिव ड्रग्स. सो दे आर गिवन एज एन एड ऑन ड्रग विद एस्पिरिन in the treatment of MI. But remember, important question, prasugrel, ticagrelor and cangrelor, last वाले 3 drug, they are contraindicated in stroke patient. They are only given in MI patient. prasugrel, ticagrelor और cangrelor, remember, इनको हम सिर्फ और सिर्फ MI वाले पेशेंट में देते हैं, स्ट्रोक में नहीं देते. Next class of drug we have is phosphodiesterase 3 inhibitor. How we can remember? P for pentoxifylline, D for dipyridamol, 3 is the third alphabet. The drug is cilostazole. These drugs are given as an add-on drug with aspirin for the treatment of stroke and Burgess disease. Remember, these drugs are contraindicated in MI patient. Fine. तो एस्पिरिन हर जगह दिया जाता है. ग्रेल और ग्रिलॉर वाले जो ड्रग्स हैं, वो स्ट्रोक में नहीं देने. फॉस्फोडाइएस्ट्रेस इनहिबिटर स्ट्रोक में देने हैं, एमआई में नहीं देने. लास्टली वी हैव अ ड्रग GP2B3 इनहिबिटर ईट, दैट इज एप्टीफिबाटाइड. एप्सिक्सीमैब आपसे मोस्ट कॉमनली पूछा जाता है. एंड टिरोफिबैन, दे इनहिबिट प्लेटलेट एग्रीगेशन. So now tell me the answer of this question. A 52 patient with deep venous thrombosis DVT was started on a new drug. After 2 days, he presented with given finding. Which of the following drug is implicated? Remember, there is limb necrosis or toe necrosis with an, okay, it is also known as purple toe syndrome, not purple man syndrome. Purple toe syndrome. The answer is warfarin. Remember, warfarin in initial 5 days. In initial 5 days, it reduces protein C and protein S levels. Protein C and protein S are anti-clotting factor. So that is why warfarin in initial 3-5 days increases coagulation. Because of deficiency of protein C and S, there is hypercoagulable state. It can lead to limb necrosis or toe necrosis. But remember, what about heparin? Remember, heparin after 5 days. Heparin after 5 days increases thrombosis. Warfarin क्या करता है बेटा? इनिशियल 5 दिन में करता है. हेपेरिन से भी हो सकती है, बट आफ्टर 5 days it causes one dangerous side effect known as HIT, जिसमें thrombosis हो सकती है. That is heparin induced thrombocytopenia. So if you see the question is asking about 2 days. पहले 5 दिन में वॉरफरिन से कोगुलेशन बढ़ती है. आखिरी के 5 दिन के बाद हेपेरिन से ब्लड वेसल की ब्लॉकेज हो सकती है बिकॉज ऑफ दिस साइड इफेक्ट. So let's talk about oral anticoagulant. So oral anticoagulant, we have 3 drugs, vitamin K antagonists. They are also known as coumarins. Then we have direct factor 10 inhibitor and direct thrombin inhibitor. So in vitamin K antagonist, we have warfarin, acetylcoumarin, bis-hydroxycoumarin, dicumarol. They inhibit one enzyme in liver, weak or C1 enzyme, vitamin K dependent enzyme. That is why they decrease the synthesis of clotting factor 2, 7, 9 and 10 in liver. Then we have direct factor 10A inhibitor. These drugs, they will end with the word exaban. Exa means they are inhibiting factor 10A. So rivaroxaban, apixaban, edoxaban and brixaban, they inhibit factor 10 only. Then we have direct thrombin inhibitor, D for direct, TR means thrombin, inhibitor means antagonist. The drug name is dabigatran. So it will inhibit factor 2 only because thrombin is factor 2. Now remember one point, if the bleeding occurs with an oral anticoagulant drug, what is the antidote? So what is the antidote for warfarin? Warfarin antidote is vitamin K1. Agreed? Vitamin K1. What is the antidote of rivaroxaban, edoxaban, brixaban, and dexanet alpha? And dexanet is synthetic form of factor 10A. How we can remember? Xa word is coming or dexa word is coming. And what is the antidote of dabigatran? Antidote of dabigatran is idarucizumab. Antidote of dabigatran is idarucizumab. It's an antibody against monoclonal antibody against dabigatran. How to remember this word? Remember दारू वर्ड आ रहा है, dabi वर्ड आ रहा है, तो एक बात याद रखनी है, dabigatran इदारू, दारू आ रहा है इसमें, दबा के दारू पियो. Agreed? Dabigatran means दबा के. Idarucizumab, daru piyo. Idarucizumab is the antidote. Agreed? Very good. I have told you this point. Now, enoxaparin is given by which route? Anyone? This question came last to last year in NEET PG. Enoxaparin is given by which route? So, enoxaparin, it is a low molecular weight heparin, which I will be telling you. It's a low molecular weight heparin. Low molecular weight heparin is given by subcutaneous injection. IV, which heparin is given? High molecular weight heparin. Intramuscular, no anticoagulant drug is ever given by intramuscular injection. It can lead to hematoma formation. So let's talk about heparins. The first form of heparin we have is high molecular weight heparin, which is also known as unfractionated heparin. It is also known as crude heparin or simply heparin. Then we have low molecular weight heparin or fractionated heparin. These drugs, they will end with the word parin, like enoxaparin, dalteparin, tinzaparin. Then we have ultra low molecular weight heparin or synthetic heparin, like fondaparinux, idraparinux. They will end with the word ultra low molecular weight heparin. They will end with the word parinux. So let's see which clotting factor they inhibit. Remember heparins. Heparins, what is their mechanism? They activate one protein in our blood, antithrombin. They activate antithrombin 3, and antithrombin 3 can inhibit factor 10 and factor 2 inside the blood. So high molecular weight heparin inhibit both factor 10 and 2. Low molecular weight heparin factor 10 more than 2, and ultra low molecular weight heparin by activating antithrombin only inhibit clotting factor 10. So how they are given? IV, subcutaneous. So which heparin can be given intravenously? Intravenous heparin is high molecular weight heparin. Because intravenous route is given in emergency, that is why high molecular weight heparin is given in emergency situation like DIC. DIC stand for disseminated intravascular coagulation due to sepsis, abruptio placentae, HELP syndrome, which you have already learnt yesterday in gynae ops. So if any dangerous scenario is there, we give intravenous heparin. Now, which heparin requires APTT monitoring? Yes, any drug given IV should be required done monitoring. So APTT monitoring must be done with. Okay. Ticagrelor is contraindicated in stroke beta. Renal failure, remember, high molecular weight heparin is safe. Low molecular and ultra low molecular weight heparins are contraindicated. Why? Because high molecular weight is such a big molecule that it will not get filtered from the kidney. That is why high molecular weight heparin is safe in renal failure. Now, what is the antidote of high molecular weight, low molecular weight heparin? The answer is protamine sulfate. High molecular weight heparin, antidote is protamine sulfate. Low molecular weight heparin, antidote is protamine sulfate. While in fondaparinux and idraparinux, remember, we don't have any antidote for fondaparinux and idraparinux. This was last year NEET PG, INI-CET and FMGE all exam question, that we don't have antidote of fondaparinux and idraparinux. Protamine sulfate is only effective against high molecular weight and low molecular weight heparin. Remember this point. So then lastly, we have direct thrombin inhibitor, which are given parenteral or IV. So these drugs, they end with the word ruidin, like heriudin, bivalirudin, deciruidin. and lepyridine. But we have another drug, ergatroban. Trob means thrombin, AN means antagonist. These drugs are the drug of choice for the treatment of HIT. HIT stand for heparin induced thrombocytopenia, a very dangerous hypersensitivity reaction due to heparin. We give Rudin wale drug या फिर ergatroban. Try to remember ergatroban. Remember, for these drugs also we have no antidote. We have no antidote if bleeding occurs with these drugs. That is why these drugs are rarely used. They are only given in HIT. Now, which of the following options is not correctly matched? Tell me the answer of this question. Last year NEET PG question. Last year NEET PG question. Yes, Dhanushri, you are very good today. You're answering all questions very nicely. That's great. Okay. So we don't have any antidote for ultra low molecular weight heparin. That's great, beta. Last year's question. Next question. Again, this question came just 6 months back. What is the antidote of bleeding due to fibrinolytic drug like streptokinase, L-teplase, tenecteplase? What is the antidote? The antidote for fibrinolytic is C, epsilon amino caproic acid. Agreed? So let's talk about what do you mean by fibrinolytic or thrombolytic drug. Their mechanism of action is these drugs, they activate plasminogen into plasmin. And plasmin, remember, removes deposited fibrin. So fibrin gets removed by plasmin. Now we have natural enzymes. We have natural enzymes like streptokinase, urokinase. We have recombinant form of TPA. TPA stand for tissue plasminogen activator. The name itself is telling you. They will end with the word tiplase. They will end with the word tiplase. TPA word will come. Remember, retiplase and tenecteplase, they are long-acting drug. They are known as bolus fibrinolytic. They are also known as bolus fibrinolytic. Now, where fibrinolytic drug are used? The first use of fibrinolytic drug, we have to remove fibrin in STEMI. They are given in STEMI. That is ST elevated MI. They are absolutely contraindicated in NSTEMI. NSTEMI stand for non-ST elevated MI because they can cause fatal bleeding. They should be used only in life-threatening situation, that is ST elevated MI. They are also given in ischemic stroke. But remember, they are absolutely contraindicated in hemorrhagic stroke because these drugs, by removing fibrin, can start acute fatal bleeding. And the third main use is they are given in massive pulmonary embolism. They are given in massive pulmonary embolism. Best wishes, Rishu. All your hard work. So if you will remove fibrin, what will be the side effect? Remember, these drugs, their main side effect is they can start acute, fatal, internal bleeding. So these drugs can start acute, fatal, internal bleeding. They are very dangerous drugs. Streptokinase, tenecteplase drug. That is why we have antidote. Antidote of fibrinolytic is antifibrinolytic. And two drugs we have to remember. Antifibrinolytic drug, their antidote of streptokinase tenecteplase is epsilon amino caproic acid, which we have discussed in the previous section, and tranexamic acid. So overall antidote is epsilon amino caproic acid. But yes, another drug which we can give is tranexamic acid. If both options will come, you will go with EACA, epsilon amino caproic acid. So we are done with CVS, kidney and blood. Let's start with autocoids now. So autocoid, remember, you have to believe in yourself. Hai na? Chalo, let's come to sumatriptan. Sumatriptan acts on which receptor? Remember, sumatriptan acts on which receptor of serotonin? It acts on 5-HT1B1D agonist. These drugs are known as triptans. And triptans, they are given in the treatment of migraine. Which drug is 5-HT1A agonist? Buspirone. 2A word is coming. It is an anti-anxiety drug. Then we have 5-HT4 agonist. These drugs, they will end with the word pride. Anyone, any famous drug you name with the word pride? Tizapride, prucalopride, they are given in the treatment of constipation. And 5-HT3 antagonist blocker, these drugs are end with the word cetron. Heard about ondansetron? So they are given in the treatment of nausea and vomiting. They are antiemetic drug. So I hope now you have understood and cleared which drug will act on which receptor. So keeping this thing in mind, let's नहीं ग्लिमेपिराइड बेटा अलग है. ग्लिमेपिराइड है वो, गिमेप्राइड नहीं है आदित्य. इट इज ग्लिमेपिराइड है. ठीक है, तो प्राइड नहीं है, प्राइड वाला अलग हो गया, थोड़ा सा नाम चेंज है. ठीक है, डोंट गेट कंफ्यूज. ठीक है, चलो let's talk about 5-HT1B1D agonist. The drug is triptans, sumatriptan, rizatriptan, alitriptan, frovatriptan. Another drug we have is ergotamine. These drugs are given in the treatment of acute attack of migraine. So in acute attack of migraine, the overall drug of choice is triptans. The overall drug of choice is triptan. But if migraine occurs in pregnancy, then we give NSAIDs like paracetamol. Second point is rizatriptan rapid. Rapid means it is the fastest acting drug. Alitriptan most effective drug. Most effective drug is alitriptan. Prova means far. It is the longest acting drug. It is the longest acting drug. Sumatriptan is most commonly used drug. Most commonly used drug is sumatriptan. Another drug we have is ergotamine. Ergotamine can lead to one side effect, that is ergotism. So in ergotism, what happens? There is vasoconstriction. So there will be dry gangrene of fingers. There will be dry gangrene of fingers due to ergotamine. That is why what we did, we converted this ergotamine into dihydroergotamine. Dihydroergotamine has more alpha blocking action. Because of more alpha blocking action, it has vasodilatory property. Less risk of ergotism is seen with dihydroergotamine. So question comes, if we attach hydrogen, which action increases in ergotamine? Alpha blocking action increases in ergotamine. It will become more of a vasodilator. Less risk of ergotism happens if we do hydrogenation, if we attach hydrogen to ergot. So tell me the answer of this question. Last year INI-CET question. So we can straight away go migraine patient, tingling, numbness, hypertension. So the answer is ergotism. Ergotism. So what is the treatment of ergotism? Treatment of ergotism is give nitroprusside. So if a patient comes with this, give nitroprusside. Nitroprusside is a vasodilator given for the treatment of ergotism. Next question. What are the drugs for prevention or prophylaxis of migraine? Remember a mnemonic BACT. Remember a mnemonic BACT. The overall drug of choice for prevention of migraine is the overall drug of choice is beta blocker propranolol. But we know beta blocker are contraindicated in asthma. In that case, you can start anti-epileptic drug. 3 anti-epileptic drugs have been approved: valproate, topiramate and gabapentin. Which calcium channel blocker is given? Flunarizine and verapamil. Tricyclic antidepressants can also be given: amitriptyline and nortriptyline. Now we have new drugs for migraine. They are known as CGRP inhibitor. CGRP stands for calcitonin gene related peptide. Calcitonin gene related peptide, CGRP inhibitor. So first drug we have is Gepant. They will end with the word Gepant. They are given in acute attack of migraine. And we have one monoclonal antibody, Erinumab. Erinumab blocks CGRP2. It was the first monoclonal antibody approved for prevention or prophylaxis of migraine. It is a very commonly used drug in our country. Agreed? So Erinumab, how we can remember Erinumab? Remember NE word is coming. NE means it is acting on neurons. And neurons, they produce migraine. Now let's talk about drug of choice for chemotherapy. And radiotherapy induce nausea and vomiting. Let's make the short form. Chemotherapy and radiotherapy induce nausea and vomiting. The first drug you will always start is cetrons. The first drug which is always started is cetrons. So they are the drug of choice for CINV, but you will write up to 24 hours. Okay? After 24 hours, we give aprepitant. Hyoscine, it is given for motion sickness, vomiting due to motion sickness. Lorazepam, it is given for anticipatory vomiting. Anticipatory vomiting means before surgery or before any fear. When become fearful, sometimes vomiting happens, we can give lorazepam. Okay, yes beta, Harsha, galcanezumab, eptinezumab, firmanizumab, the three more new monoclonal antibodies have been approved for migraine, but for NEET they have never been asked. In NEET only erinumab has been asked. Okay, done. So that things I have discussed in rapid revision, all four monoclonal antibodies. So let's talk about chemotherapy induced nausea and vomiting. Question comes, chemotherapy means anti-cancer drug. Which anti-cancer drug causes maximum nausea and vomiting? Remember, cisplatin causes maximum nausea and vomiting. So if the patient is having CINV, chemotherapy induced nausea and vomiting, overall drug of choice is cetron, like ondansetron, granisetron. Agreed? But they are effective up to 24 hours. 24 hours means early phase. Early phase, there is one exception, palonosetron. Palonosetron is effective beyond 24 hours also. Beyond 24 hours, we call it as delayed phase of CINV. But what we will do for beyond 24 hours? Beyond 24 hours or delayed phase of chemotherapy-induced nausea and vomiting, we give a drug pitant. Pitant वाले drug देंगे. Pitant are NK1 antagonist. Last year MCQ. NK1 stand for beta neurokinin. They block neurokinin receptor. So the drugs are aprepitant, netipitant, rolapitant. So they are also antiemetic drug given in delayed phase of chemotherapy induced nausea and vomiting. If it is still not controlled, we add corticosteroid dexamethasone. If it is still not controlled or refractory cases of chemotherapy induced nausea and vomiting, we add a drug CB1 or cannabinoid agonist. Remember, they are not antagonists, they are agonists. So how to remember? You have to identify NABI word in them. So the first drug which is cannabinoid agonist is nabilone, and the second drug we have is dronabinol. तो नाबी वर्ड दोनों में आ रहा है, कैनाबिनॉइड में भी नाबी वर्ड आ रहा है. तो रिमेंबर दीज ड्रग्स हैव एंटीएमेटिक एक्शन एंड वी नो जब हम भांग, चरस, गांजा या कैनाबिनॉइड लेते हैं हमें बहुत भूख लगती है. विच एंटीएमेटिक ड्रग increase or stimulate appetite is cannabinoid, that is nabilone and dronabinol. Okay, now let's talk about, no beta, in refractory olanzapine can also be given, I have told you in rapid revision, but right now for LRR not important. In it has not never been asked basically. Okay, but I have told you that point. Now tell me the answer. Prokinetic drug like prucalopride. Pride word आ गया बेटा आपका वाला. कहाँ यूज करोगे pride वाला drug? Pride वाला drug कहाँ दोगे? Pride वाला drug हम देते थे treatment of constipation. पढ़ा था, very commonly used drug in India. Okay, they are given in the treatment of constipation. Okay, now what do you mean by prokinetic drug? Pro का मतलब होता है बेटा increase करना. काइनेटिक का मतलब दे विल इंक्रीज जीआईटी मोटिलिटी. तो अगर बेटा जीआईटी की मोटिलिटी बढ़ाओगे तो क्या होगा? दे आर गिवन इन 3 कंडीशन. दे आर गिवन इन द ट्रीटमेंट ऑफ कॉन्स्टिपेशन. प्रोकाइनेटिक ड्रग फर्स्ट यूजेस दे आर गिवन इन कॉन्स्टिपेशन. सेकंड, जब स्टमक पैरालाइज पड़ा है, गैस्ट्रोपेरेसिस. एंड थर्ड, दे आर ऑल्सो गिवन इन द ट्रीटमेंट ऑफ जीईआरडी. वाई? बिकॉज दे विल क्लोज विच स्फिंक्टर. मोटिलिटी बढ़ेगी तो कौन सा स्फिंक्टर बंद हो जाएगा? लोअर इसोफेजियल स्फिंक्टर बंद हो जाएगा. नाउ हाउ टू आइडेंटिफाई एंड रिमेंबर दिस पॉइंट? रिमेंबर हमारे जीआईटी में जो सेरोटोनिन है वो मोटिलिटी को बढ़ाता है. सेरोटोनिन इंक्रीजेस मोटिलिटी. एसिटाइल कोलिन आल्सो इंक्रीजेस मोटिलिटी. but dopamine decreases motility. Dopamine GIT की motility कम करता है. So don't you think we should stimulate serotonin and acetylcholine receptors, and we should block dopamine receptor? These drugs will be prokinetic. So keeping this thing in mind, first is serotonin का 5-HT4 agonist. Agonist word समझ आया? सेरोटोनिन के कौन से रिसेप्टर को स्टिमुलेट किया? 5-HT4 एगोनिस्ट. तो इन ड्रग के एंड में क्या वर्ड आ रहा है? प्राइड वर्ड आ रहा है. प्राइड वर्ड आ रहा है. तो सीजाप्राइड, मोजाप्राइड, प्रूकेलोप्राइड. सर एक नाम अलग है जिसको हम लिखेंगे टीगासिरॉड. एक नाम अलग है टीगासिरॉड. तो दे ऑल आर गिवन इन 3 कंडीशन: GERD, कॉन्स्टिपेशन एंड गैस्ट्रोपेरेसिस. सीजाप्राइड और टीगासिरॉड का साइड इफेक्ट है दे कॉज QT प्रोलॉन्गेशन. इनका साइड इफेक्ट क्या है? QT प्रोलॉन्गेशन. देन वी हैव डोपामीन एंटागनिस्ट. डोपामीन के रिसेप्टर को ब्लॉक कर दो. द ड्रग नेम इज डोमपेरिडोन. डोमपेरिडोन के साथ लिखोगे इट इज अ प्रोकाइनेटिक ड्रग, प्लस इट ऑल्सो हैज एंटीएमेटिक एक्शन. ये वॉमिटिंग भी कम करता है क्योंकि ये डोपामीन के रिसेप्टर को CTZ पे भी ब्लॉक करता है. एंड लास्टली वी हैव अ ड्रग एंटीकोलिनेस्टेरेस, नियोस्टिग्मिन. नियोस्टिग्मिन भी हम यूज करते हैं. नाउ वी हैव अ ड्रग जिसके ऑल 3 एक्शंस हैं. ऑल 3 एक्शंस किसके हैं? All 3 actions are there of a drug known as metoclopramide. कौन से ड्रग के सारे एक्शंस होते हैं बेटा? पहले तीनों एक्शन होते हैं. 5-HT4 एगोनिस्ट भी होता है, 5-HT4 एगोनिस्ट भी होता है, डोपामीन ब्लॉकर भी होता है, और एसिटाइलकोलिन का लेवल भी बढ़ाता है. All 3 actions are seen with a drug known as metoclopramide. Agreed? So now you know where metoclopramide is given. Metoclopramide is given in GERD, constipation and gastroparesis, but there is a point. Tell me the answer of this question. Very frequently asked question. A patient of schizophrenia presented to emergency with muscle spasm, upward gazing of eyes, bradykinesia, gait abnormality. So patient is suffering from the symptoms of Parkinson's disease, which is also known as muscle dystonia. It is also known as muscle dystonia. What is the next step in management? Remember, this Parkinson disease is caused by which drugs? It is caused by which drug? It is caused by first metoclopramide. So metoclopramide is an antiemetic drug which can cause drug-induced Parkinsonism. And the second class of drug which can cause drug-induced Parkinson disease is antipsychotic drugs. दो नाम याद रखेंगे, हेलोपेरिडोल एंड रिस्पेरिडोन. Why these drugs can cause drug-induced Parkinsonism? Because these drugs they block dopamine receptor in basal ganglia. ये ब्रेन में एंटर कर जाते हैं और डोपामीन का रिसेप्टर ब्लॉक करते हैं. ट्रीटमेंट ऑफ ड्रग इंड्यूस्ड पार्किंसोनिज्म इज, ट्रीटमेंट इज बेंजहेक्सोल. हमने कल पढ़ा था बेंजहेक्सोल इज एन एंटीकोलिनर्जिक ड्रग. इट इज गिवन फॉर द ट्रीटमेंट ऑफ ड्रग इंड्यूस्ड पार्किंसन डिजीज. सर ये 3 ड्रग तो करते हैं. Now understand the difference between domperidone and metoclopramide. Domperidone do not cross blood-brain barrier, while metoclopramide it can cross blood-brain barrier. Because of this reason, the first side effect of metoclopramide is Parkinson disease, which is also known as muscle dystonia. And because of blockage of dopamine receptor, it can also elevate prolactin levels. Prolactin levels are also elevated. So these side effects are not seen with domperidone. It is seen with metoclopramide. And how to treat this drug-induced Parkinsonism we already know. We give benzoxazole. So which of the following drug is given for maintaining patency of ductus arteriosus? Remember, to open ductus arteriosus or to close a patent ductus arteriosus, which drug we give? To open ductus arteriosus, we give a drug L-prostadil. And L-prostadil is prostaglandin E1. It is E1. Now to close ductus arteriosus, we give ibuprofen, and we give indomethacin. These are the two approved drugs, and these drugs are NSAID, non-steroidal anti-inflammatory drug, which decrease prostaglandin production. Overall drug of choice is ibuprofen, but the most commonly used drug is indomethacin. Most commonly used drug is indomethacin. So let's talk about various prostaglandins, beta. First type of prostaglandin is PGE1. And we have three drug in prostaglandin E1, misoprostol, लिखेंगे misoprostol, drug of choice for MTP. You know what is MTP? Medical termination of pregnancy abortion up to 63 days. So up to how many days we can give? 63 days. It can be given for the treatment of aspirin या फिर NSAID induced peptic ulcer. But remember, any peptic ulcer comes, always the drug of choice is PPI, proton pump inhibitor, but misoprostol can be given. The main side effect of misoprostol is diarrhea. Why? Because it increases chloride secretion in intestine. That is why we made a drug lubiprostone. Lubiprostone is a laxative. Laxative means it causes diarrhea. How it causes diarrhea? It causes chloride secretion. That is why lubiprostone is given in the treatment of constipation in IBS. IBS is irritable bowel syndrome. L-prostadil, beta, we already know where it is given. It is given to open ductus arteriosus. It is given to open ductus arteriosus. Very good, beta. Mobius syndrome we discussed yesterday. Now we have prostaglandin E2. E2 का मतलब दो है ना, दो. तो dinoprostone vaginal creams are available. Because vaginal creams are available, it is given to dilate cervix. Dilatation of cervix is known as cervical ripening. But prostaglandin F2 alpha, we have dinoprost. Don't get confused between dinoprostone and dinoprost. Dinoprost and dinoprostone, they are given for second trimester abortion. In first trimester abortion, we were giving prostaglandin E1. E1 था misoprostol. 1 का मतलब फर्स्ट ट्राइमेस्टर अबॉर्शन. कहीं भी 2 वर्ड आता है, सेकंड ट्राइमेस्टर अबॉर्शन. Then we have carboprost. Carboprost, it is given to control postpartum hemorrhage, which is resistant to oxytocin, because it will contract uterus. The dose of carboprost is 250 microgram 250 microgram injection, and in one day you can give maximum 8 injection. So in one day the total dose will become 2000 micrograms. And carboprost, remember, it is contraindicated in asthma. These are a very commonly asked question, which is very commonly asked question. Okay. Now adverse effect of NSAID. First point, what are NSAIDs? NSAIDs are COX inhibitor. Because they are COX inhibitor, they inhibit the conversion of arachidonic acid into prostaglandins, and thromboxane A2 production will be fine. So this is the mechanism of action of NSAID, non-steroidal anti-inflammatory drug. First is aspirin. Remember, aspirin is the only irreversible COX inhibitor. It is the only irreversible COX inhibitor. So we have discussed aspirin. Its main side effect is peptic ulcer. Why? Because aspirin shows iron trapping inside stomach cell. And we know any drug of choice for any peptic ulcer is always PPI. We will discuss aspirin shortly. Nimesulide banned because it was hepatotoxic, especially in children less than 15 years of age. and it causes Stevens-Johnson syndrome. Phenacetin banned because of analgesic nephropathy. Remember, all NSAIDs, they can cause kidney damage, they can cause papillary necrosis of kidney. Maximum it was seen with phenacetin, it got banned. Coxib word is coming. Coxib drugs, remember, they are selective COX-2 inhibitor. They are selective COX-2 inhibitor. They have great advantage, less risk of causing peptic ulcer. Maximum peptic ulcer is caused by aspirin, but their disadvantage is that these drugs, they can increase thrombus formation, which can lead to MI and stroke. Again, that is why these drugs, they got banned. These drugs, they got banned. Okay, अभी लेते हैं ब्रेक. हुआ तो ये कहानी हुई. Now what is race syndrome? Very important. Race syndrome is aspirin, especially in children, in presence of viral fever. In presence of viral fever like influenza, COVID. बेटा एक बात बताओ, क्या आपने कोविड में एस्पिरिन दिया था फॉर फीवर? हैव यू प्रिस्क्राइब्ड एस्पिरिन फॉर एनी फीवर? कोविड में दिया था हमने एस्पिरिन? नहीं दिया था, बिकॉज ऑफ द रिस्क ऑफ रेस सिंड्रोम. तो इन दिस कंडीशन समटाइम्स एस्पिरिन कैन कॉज fulminant लिवर डैमेज. लिवर डैमेज हो जाता है. लिवर डैमेज होने की वजह से पेशेंट को एनकेफेलोपैथी हो जाती है. तो दिस सिंड्रोम इज रेस सिंड्रोम, है ना. इसीलिए दैट इज व्हाई वी नेवर गिव एस्पिरिन एज अ to reduce fever, especially in children. In fact, aspirin is not given in children less than 18 years of age, except in Kawasaki disease. Then we have samtostriide. Samtostriide is mainly seen with aspirin. But remember, other NSAIDs can also produce. Other NSAID can also lead to samtostriide. So with aspirin, there will be asthma, and there is ethmoidal polyp in nose. Ethmoidal polyp in nose. So these are allergic reactions which increases with aspirin. Okay, but other NSAIDs can also produce. Fine, fine. Next we have is, what is the safest drug in children? Always the safest drug in children, renal failure, is always and always acetaminophen. Acetaminophen is also known as paracetamol. So paracetamol is always and always, remember, it is the safest drug, but question comes very frequently on paracetamol. So paracetamol, aceta word is coming, it is also known as acetaminophen. So its main mechanism of action, it inhibits COX-3 enzyme in brain, and it also stimulates TRPV1 receptor. It stimulates some TRPV1 receptor. One question came. Remember, paracetamol is always the safest drug in children. It is the safest drug in pregnancy. It is the safest drug in peptic ulcer because it does not causes peptic ulcer. It is the safest drug in renal failure. Overall, the safest drug is paracetamol. Now, what is the main problem of paracetamol? If you give paracetamol more than 4 grams per day, it goes to the liver and it forms a toxic form. The toxic form of paracetamol is NAPQI. Normally, this NAPQI is removed into the urine with the help of a protein produced in liver known as glutathione. So glutathione normally removes NAPQI. Agreed this part? Now what this NAPQI causes? NAPQI causes hepatotoxicity. So what is the main side effect of paracetamol? It causes hepatotoxicity. Now the first point is, which drug depletes glutathione? Alcohol. Alcohol depletes glutathione. Alcohol depletes glutathione. Agreed? That is why in alcoholics there is high risk of causing hepatotoxicity due to paracetamol. So what is the antidote of paracetamol hepatotoxicity? That is N-acetylcysteine. Why we give N-acetylcysteine? N-acetylcysteine increase the levels or regenerate glutathione. So because it regenerates glutathione, it will remove the toxic form of paracetamol, that is NAPQI. This was previous year MCQ. So why we give N-acetylcysteine? Because it regenerates the level of glutathione, which helps in removal of NAPQI. Very good beta, shabash. तो टॉक्सिक फॉर्म है NAPQI और एंटीडोट क्या है बेटा? NAC. एंटीडोट NAC है, टॉक्सिक फॉर्म क्या है? NAPQI. So which of the following is the mechanism of action of colchicine in acute gout? Remember, colchicine is a microtubule inhibitor. It is a microtubule inhibitor. Microtubule is required for migration of WBC. So it will inhibit migration of WBC. That is why it has anti-inflammatory action. It has anti-inflammatory action during acute attack of gout. So what are the drugs we give in acute attack of gout? In acute attack of gout, there is arthritis. The most commonly involved joint is toe joint, like metatarsophalangeal joint. So there is pain, redness and swelling. The overall drug of choice is NSAIDs. All NSAIDs can be given except aspirin and paracetamol. Aspirin itself increases uric acid level. That is why we avoid aspirin in gout patient. Paracetamol has a very poor anti-inflammatory action. That is why paracetamol and aspirin are the two NSAIDs which are not given. Chill refractory, give colchicine. Chill refractory, give corticosteroid. So this is the treatment of acute attack of gout. Now let's talk about treatment of chronic gout. For that, solve this question which was recently asked. So which drug degrades uric acid into allantoin? Which drug in blood degrades uric acid into allantoin? One enzyme name is RUSP uricase. So RUSP uricase degrade. So let's talk about now chronic gout. In chronic gout, we have to reduce blood uric acid level. So how uric acid is produced? Uric acid is produced from one purine known as hypoxanthine. Hypoxanthine goes to the liver. There is an enzyme, xanthine oxidase enzyme, which converts this hypoxanthine into uric acid. Then this uric acid is excreted in urine. Then it is excreted out in urine. So the first drug we have is xanthine oxidase inhibitor. So xanthine oxidase inhibitor, how we can remember? Very simple and easy. See the name, allopurinol, oxypurinol. So they are fake purines. Because they are fake purines, they are competitive inhibitor of xanthine oxidase enzyme. So purine word is coming. Next drug we have is febuxostat. Exo word is coming, stat word is coming. Exo means it is a xanthine oxidase inhibitor. It is a non-competitive inhibitor. So these drugs are now considered to be the drug of choice for chronic gout. So what are the causes of chronic gout? One cause you have to remember is CKD, kidney failure. Second cause you have to remember is tumor lysis syndrome. So in cancer patient, when we give anti-cancer drug, DNA becomes damaged, cell becomes damaged, and the patient suffers from gout. The another drug we have is the drug, these are enzymes. These enzymes in blood convert uric acid into a harmless molecule, that is allantoin. So let's oxidize this uric acid into a harmless molecule. So the drugs are uric acid oxidase enzyme. So enzymes, they will end with the word ase. Rusburicase and pegloticase enzymes are protein are given IV. Pegloticase is mammalian enzyme. Rusburicase is an enzyme obtained from the blood. They are given in resistant cases of tumor lysis syndrome. Very commonly asked MCQ. Lastly, we have a drug, uricose uric agent, that will increase the excretion of uric acid into the urine. Try to remember the first drug, probenecid. Try to remember benzbromarone, lesinurad and desinurad, new drug. These drugs are rarely used because they increase the risk of uric acid stones in kidney, because they increase the excretion of uric acid into urine. Next question is rheumatoid arthritis. The drug which we give in the treatment of rheumatoid arthritis is our DMARD. DMARD are disease modifying anti-rheumatic drug. Now remember, the drugs which are among DMARDs or disease modifying anti-rheumatic drug we have is Malika Sherawat Pagal C. And these drugs are conventional or old DMARDs. Old DMARDs. Malika Sherawat Pagal C. So we have methotrexate, sulfasalazine, penicillamine, gold, leflunomide, chloroquine and hydroxychloroquine. Okay, I will be telling you how to remember. Now the first point is, which drug is the safest DMARD in pregnancy? Remember, safest DMARD in pregnancy is hydroxychloroquine. Recent MCQ. But what is the most effective DMARD? Most effective drug for methotrexate is rheumatoid arthritis is methotrexate. So methotrexate is the most effective drug. I will be telling you about methotrexate in anti-cancer chapter. Don't worry. Now, with this hydroxychloroquine, you can add, if you want, sulfasalazine. Now remember, sulfasalazine, it is given for the treatment of rheumatoid arthritis. It is also given for the treatment of UC. UC is ulcerative colitis. It is also given in the treatment of ulcerative colitis. In ulcerative colitis, we have drug which will end with the word sala. इनमें साला वाले ड्रग आएंगे. Remember, like misalazine. These are the new drug. Olsalazine. तो रिमेंबर, किसी भी ड्रग में साला साला वर्ड आएगा वो अल्सरेटिव कोलाइटिस में होगा. मिसालाजीन याद कर लो. हाउ टू रिमेंबर दिस पार्ट? रिमेंबर, ज्यादा मसाला खाओगे, ज्यादा मसाला खाओगे तो क्या होगा? आपके इंटेस्टाइन में या कोलोन में अल्सर होने लग जाएंगे. तो मसाले वाले ड्रग आर गिवन इन द ट्रीटमेंट ऑफ अल्सरेटिव कोलाइटिस. ओके, agreed, understood. Now in methotrexate resistant, remember methotrexate is absolutely contraindicated in pregnancy. We discussed yesterday. And remember, in methotrexate resistant cases, we add biological DMARDs. कौन से ड्रग देते हैं हम? methotrexate resistant cases में हम क्या करेंगे? Will add biological DMARDs. Now what is biological DMARD? I will be telling you. Okay, I will be telling you. Now remember, penicillamine and sulfasala and gold, they are nephrotoxic drug, nowadays not used. Leflunomide inhibit one enzyme, DHOD enzyme, DHOD enzyme, dihydroorotate dehydrogenase enzyme, dihydroorotate dehydrogenase enzyme. Remember the short form. Now tell me one biological DMARD I am going to tell you. Tocilizumab, which is a drug for rheumatoid arthritis. It acts by blocking interleukin 6. Agreed? Interleukin 6. There is a drug that will block interleukin 1, anakinra, drug for rheumatoid arthritis. ठीक है, a new drug for rheumatoid arthritis. A और kin means it will block interleukin, इसीलिए kin word आ रहा है. A means first alphabet, interleukin 1. Now let's talk about the important biological DMARDs which are given as an add-on drugs. Biological DMARDs which are given as an add-on drug to methotrexate and rheumatoid arthritis. First is TNF alpha blocker. The drugs are ICAGE. You have to remember the name. I for infliximab, C for certolizumab. Adalimumab is a very commonly asked MCQ. Golimumab and etanercept. Then we have anti-interleukin 6 inhibitor, tocilizumab, sarilumab. We have Janus kinase inhibitor. They will end with the word citinib. Tinib word will come. So tofacitinib, baricitinib, upadacitinib. Try to remember tofacitinib. And we have a drug rituximab. एक लड़की थी रितु. रितु की एज थी 20 साल. रितु की एज थी 20 साल. CD20. It blocks CD20. That is rituximab. Remember, these drugs, they are given in the treatment of RA. Okay, the drugs I am marking, that is these drugs, they are given in the treatment of RA. Tofacitinib, ठीक है, tofacitinib को भी mark कर लो. They are also given in the treatment of IBD. They are also given in the treatment of IBD also. IBD is inflammatory bowel disease. So tofacitinib, very commonly asked question. Last year NEET MCQ, NEET PG MCQ, tofacitinib, infliximab, certolizumab, adalimumab, these drugs are also given in the treatment of IBD, inflammatory bowel disease. Now, one side effect of infliximab, it can lead to reactivation of latent TB because you are removing TNF alpha, TB will reactivate. That is why before giving infliximab, you must do MON2 test in your patient. So you must do MON2 test in your patient. So this finishes our autocoids as well. So let's start with now endocrine chapter. You want break or shall I continue? I can continue for another half hour if you want. Okay? So you want break or shall I continue, because some students they were asking for break, so can't be continue. Let's start with endocrine. After half an hour we will take a break. Okay? After half an hour. So which drug is now considered to be the longest acting insulin? Now the longest acting insulin drug has become degludec insulin. Earlier it was glargine. Okay? So let's talk about various insulin. So remember, we have ultra short or rapid acting insulin which act for 3 hours. You have to identify S word, Lispro, Aspart and Glulicine. Then we have short acting insulin which act for 6 hours. We have regular insulin. Agreed? Now, then we have intermediate acting insulin which act for 12 to 15 hours. One is lente insulin, second is NPH, neutral protamine H-DON insulin. We have long acting insulin, detemir, glargine which act for 24 hours, and we have the longest acting insulin, degludec. Degludec now has become the longest acting insulin. It rather acts for 42 hours. The first two insulin, remember, they are given as a bolus insulin. Bolus insulin means they are given before meals to control PPH. While other insulin, they are given as a basal insulin. Intermediate, long and ultra long acting insulin, they are given as a basal insulin for long term maintenance of insulin level in the body. Now, which insulin is also given IV? So, which insulin is also given IV? IV, regular insulin can also be given IV. And IV drug are given always in emergency. So, it is considered to be the drug of choice for DKA. DKA stand for diabetic ketoacidosis. HHS, that is hyperglycemic hyperosmolar state. It is also considered to be the drug of choice for the treatment of hyperkalemia, because insulin makes this potassium from the blood enter into the tissues like muscles and fat. Insulin reduces blood potassium level. Now, which insulin would you like to consider as peakless insulin? Can we say long acting insulin don't have peak? So peakless insulin is glargine and degludec. They are considered to be the peakless insulin because they are very long acting insulin, so no peak will come. So glargine is an acidic insulin, so we never mix with other insulin in same injection. So which insulin should never be mixed with other insulin in same injection? Glargine. Recently a new insulin got approved, nasal insulin. Nasal insulin which has been approved is Afrezza. Afrezza is a very short acting insulin. That is why it is given as a bolus insulin. Bolus insulin means it is given before meals to control postprandial hyperglycemia. The question which was asked is that Afrezza must be combined with it must be combined with injections of basal insulin. You cannot give Afrezza alone in your patient, so you have to give injections of basal insulin along with Afrezza. Agreed? So because it's a nasal, the side effect will be asthma, contraindicated in smokers, but this point has never been asked. So which drug for diabetes can cause hypoglycemia? This is a very, very frequently asked question. Very repetitive question coming from past 3-4 years continuously. Remember, let me give you a trick. There are only 3 classes of drugs in diabetes which can cause hypoglycemia. The first is insulin. Second is some sulfonylurea. Remember, sulfonylurea, they will end with the word amide or they will start with the word gly. And the third class of drug, we will have some meglitinide They will end with the word glenide. They will end with the word glenide. So I have given you a trick now. A drug ending with the word amide, a drug starting with the word glee, or the drug ending with the word glenide. Only these drugs, they produce hypoglycemia in diabetes. Now tell me the answer. Now tell me the answer of this question. Can we say glee word is coming? So the drug is glipizide. The drug is glipizide. Very good. Okay. So let's discuss all oral hypoglycemic agent drug. So first is sulfonylurea. How to identify their name? Sulfonylurea first generation, they will end with the word amide. All of them will end with the word amide. Try to remember chlorpropamide. And second generation, they will start with the word glee, like glimepiride, glipizide, gliclazide, glyburide. Remember this part. Now why we made second generation? Because they are more potent. They are more potent than first generation. Then we have meglitinide. Meglitinide, they will end with the word glenide. Now both these classes of drug, what is their mechanism of action? These drugs, they increase insulin secretion from beta cells of pancreas. How? By blocking, they block potassium channel. Which potassium channel? They block ATP sensitive potassium channel on beta cell of pancreas. That is why they produce insulin secretion. They produce insulin secretion. Remember these drugs, remember they produce hypoglycemia as a side effect. Yes, because they are causing insulin secretion. Insulin is an anabolic hormone. These drugs, they produce weight gain. These drugs, they produce weight gain. Among them, chlorpropamide is an important drug. Chlorpropamide, remember, it causes disulfiram-like reaction. And any drug which causes disulfiram-like reaction must be avoided in alcoholics. And chlorpropamide is also given in the treatment of diabetes insipidus. Why? Because it increased the secretion of ADH hormone. That is why chlorpropamide is also given in the treatment of diabetes insipidus. Next class of drug we are having is GLP-1 agonist. GLP-1 stands for glucagon like peptide 1. So glucagon like peptide is a type of incretin. So these drugs are incretins. As the name tells you, incretins also increase insulin secretion. So these drugs, they will end with the word nartide. How to identify? They will end with the word nartide or they will end with the word glutide. इनके एंड में नाटाइड या ग्लूटाइड वर्ड आएगा. एक्जेनाटाइड, लिक्सेसेनाटाइड, एल्बिग्लूटाइड, ड्यूलाग्लूटाइड, liraglutide and semaglutide. Most commonly asked question. Now because they are ending with the word tide, remember any drug that ends with the word tide is a peptide. कोई भी ड्रग जो टाइड वर्ड से एंड करता है वो पेप्टाइड होता है. एंड रिमेंबर पेप्टाइड्स आर ओनली गिवन बाय इंजेक्शन. इनको आप ओरली नहीं दे सकते. So these drugs are given by injection. All drugs are given by injections. But this semaglutide, recently now we have ओरल फॉर्म ऑल्सो. कौन सा ड्रग अब ओरली भी अवेलेबल है? विच ड्रग नाउ हैज बीन अवेलेबल ओरली एज वेल? Semaglutide is available orally. Now a new drug is tirzepatide. Very high chances that this drug might be asked this year in NEET exam. Tirzepatide is dual GLP-1, that is glucagon like peptide, and GIP agonist. GIP is some glucose dependent insulotropic peptide. Full form we don't have to remember. So it's a new drug for treatment of type 2 diabetes mellitus. Another drug is teduglutide. Tedu का मतलब है T word आ रहा है. It is GLP-2 agonist. It is not GLP-1. It is rather GLP-2 agonist and it is given for the treatment of short bowel syndrome. क्योंकि GLP-1 गुड फॉर डायबिटीज, इंक्रीज इंसुलिन सिक्रीशन. GLP-2 जो होता है वो बेटा इंटेस्टाइन की ग्रोथ कराता है. इट कॉजेज ग्रोथ ऑफ इंटेस्टिनल सेल. Teduglutide is GLP-2, not GLP-1. That is why teduglutide is given in short bowel syndrome. It causes growth of intestinal cells. Now, what are the side effects of all these drugs? All these drugs, they can cause pancreatic damage, pancreatitis, They increase the risk of pancreatic and thyroid cancer. Agreed? So you must have, yes, tirzepatide is also parenteral, injectable. So you must have seen about this guy. He has become very thin because he's on a medication, this medication. Which medication? Semaglutide. Remember these three anti-diabetic drugs, very commonly asked, probably this question will come or this question will come. Sorry, this will come. These two drugs are high chances that they will be asked this year. So which anti-obesity drug are approved recently? Because these drugs, they produce weight loss. So you can remember a mnemonic, STIM. Still, एक mnemonic याद कर लो, still. Semaglutide, tirzepatide and liraglutide are the three anti-diabetic drugs which are also approved as an anti-obesity drug. And this guy, he has become so thin, he was taking this drug, semaglutide injection. He was taking semaglutide injection. Agreed? It comes with the brand name Ozempic. So next we have is DPP4 inhibitor. DPP stand for dipeptidyl peptidase inhibitor. So these drugs, they will end with the word gliptin. So if you inhibit DPP enzyme, they increase the level of endogenous GLP-1. That means they increase the level of endogenous incretins, because incretins in our body are degraded by DPP enzyme. So these drugs are given orally. They are weight neutral drugs. And their main side effect is gliptins. Their main side effect is arthritis. Arthritis means joint inflammation, joint pain will happen. They can also cause a running nose because of nasopharyngitis. Agreed? Now, among them, remember this word, linagliptin. It is the safe drug in renal failure. कौन सा ड्रग सेफ है रीनल फेलियर में? लीनाग्लिप्टिन रीनल फेलियर में लेना है. This is a very, very frequently asked question. Then we have a drug metformin. Metformin acts on liver and metformin inhibit hepatic gluconeogenesis. Metformin inhibit hepatic gluconeogenesis. That means it inhibits the conversion of lactic acid into glucose. And this is the action of insulin on liver. That is why metformin reduces resistance of insulin on liver. It reduces peripheral resistance. Metformin is the drug of choice for type 2 diabetes mellitus. It is also the drug of choice for IGT, impaired glucose tolerance or pre-diabetes. It is also the drug of choice for diabetes which is seen in type 2 diabetes which is seen in PCOD. Now the main side effect of metformin, very commonly asked, most common side effect of metformin is unexplained diarrhea. This year NEET question. This year NEET question, a drug producing diarrhea. What is the culprit? Metformin. Metformin causes megaloblastic anemia because it reduces the absorption of vitamin B12, vitamin B12 deficiency. Because it is inhibiting hepatic gluconeogenesis, the levels of lactic acid will increase. Lactic acidosis will happen. Because of the risk of lactic acidosis, remember, metformin is absolutely contraindicated in renal failure. तो रीनल फेलियर में बेटा कौन सा दे रहे हो? रीनल फेलियर में लीनाग्लिप्टिन देना है, मेटफॉर्मिन रीनल फेलियर में नहीं देना. इट्स अ वेरी वेरी कॉमनली आस्क्ड क्वेश्चन. So keeping this thing in mind, solve this MCQ which was asked last year in NEET exam. A patient on diabetes was given oral hypoglycemic agent which reduced her HbA1c from 7.6 to 6.7. On testing, the patient has high GLP-1 level. High GLP-1 level. So GLP-1 level has been increased. Which drug increases? Which drug increases GLP-1 level? Yes, Aviator, you are absolutely right. DPP4 inhibitors. They increase the level of GLP-1. Last year NEET question. That's great. Shabash. Tell me the answer of this question. This was the exact question. Which of the following anti-diabetic drug can cause unexplained diarrhea? The answer is metformin. But yes, another drug which you can write is acarbose. But acarbose was not given in the option. So you will go with metformin. Because metformin inhibits bile absorption, which can lead to diarrhea. In renal failure, which of the listed medication does not require dose adjustment? Which drug does not require dose adjustment in renal failure? Which drug is safe in renal failure? Answer. Which gliptin? Yes, linagliptin. And a new drug which has been approved is teneligliptin. Teneligliptin is a new drug which is also renal safe. So these are the two new drugs which are safe in renal failure. Linagliptin and teneligliptin एक नया drug है. So this is how this LRR is different from the previous LRR. Some students are asking me. So I'm telling you various new drugs as well. Okay. Next is acarbose, voglibose, miglitol. They are alpha glucosidase inhibitor. They inhibit breakdown of complex carbohydrate in intestine. So complex carbohydrate like sucrose, starch are not broken down. So they are taken before meals. We give this drug before meals to control PPH, postprandial hyperglycemia. So their main side effect is again diarrhea. And the very important point is if the patient is taking acarbose, remember one point, sucrose is not effective. That is table sugar is not effective in correcting hypoglycemia. If the patient is suffering from hypoglycemia and the patient is on acarbose, sucrose and table sugar will not be effective because it will not be broken down into glucose and fructose. It's better to give pure glucose or pure fructose. Honey is a very good source of fructose. Then we have thiazolidinedione. You don't have to remember this word. So these drugs they end with the word glitazone. So these drugs are PPAR gamma agonist. So they are PPAR gamma agonist. So any other drug which is a PPAR gamma agonist? Yes, one drug, telmisartan, is also PPAR gamma agonist. It is also a PPAR gamma agonist, sartan. Now, pioglitazone like drug, what is their side effect? Remember, rosiglitazone banned. Why? MI and heart failure. Proglitazone banned. Why? Hepatotoxic. So which drug is available? Pioglitazone is available, but pioglitazone comes with a warning that it increases the risk of urinary bladder cancer. But it comes with a warning that it increases the risk of urinary bladder cancer. Agreed? Fine. Now, I was waiting for this slide. And mark my words, beta. Mark my words that question will come from these drugs. It is coming in each and every exam from past 5 years continuously. We have developed a new beautiful drugs for diabetes. These drugs are SGLT2 inhibitor. Question will definitely come this year also on SGLT2 inhibitor. So remember, it is very important. Don't miss this word. Hai na? At least one or two questions will come from here. So SGLT2 inhibitor are sodium glucose transporter inhibitor. So this transporter is present in kidney. If you inhibit this transporter, remember SGLT2 inhibitor, they will end with the word gliflozin. So how to remember? Flow word is coming. If flow word is coming, can we say they will increase urine flow? ये यूरिन के फ्लो को बढ़ाते हैं ग्लिफ्लोजिन. हाउ दे इंक्रीज यूरिन फ्लो? They increase sodium and glucose excretion. So these increase glucose, sodium and glucose excretion. We have a drug sotagliflozin. It is a dual SGLT1 plus 2 inhibitor. ऊपर वाले ड्रग क्या है? सिर्फ और सिर्फ ऊपर वाले ड्रग सिर्फ SGLT2 inhibitor है. Now because they increase sodium excretion, they have diuretic effect. They have anti-hypertensive effect. Because of diuretic and anti-hypertensive effect, they are protective drugs in CHF. So they are cardioprotective drugs in CHF and they are nephroprotective drugs in CKD. So they have cardioprotective effect in chronic heart failure. They have nephroprotective effect in CKD, chronic kidney disease. Because they excrete glucose, they are given for type 2 diabetes mellitus. Now, what is their main side effect? Because of glucose excretion, they will produce glycosuria. They will lead to glycosuria. Because of glycosuria, they increase the risk of UTI. UTI stand for urinary tract infection. They can increase bacterial infection. They can also lead to candida infection. Fungal infection भी बढ़ जाते हैं. They also increase the risk of osteoporosis because they increase calcium excretion. And lastly, they increase the risk of DKA. DKA stand for beta diabetic ketoacidosis. So remember a mnemonic duo: diabetic ketoacidosis, urinary tract infection, or osteoporosis are the side effect of SGLT2 inhibitor. Now remember pioglitazone, rosiglitazone, remember these drugs have antidiuretic action. Antidiuretic action means they will increase preload. That is why these drugs are absolutely contraindicated in chronic heart failure. While gliflozin wale drug, these drugs have diuretic action. Because these drugs have diuretic action, they reduce preload on heart. That is why these drugs are given in the treatment of CHF. तो ग्लिफ्लोजिन वाले ड्रग CHF में देते हैं, ग्लिटाजोन वाले ड्रग हम CHF में नहीं देते. So tell me the answer of this question, last year's NEET question. Now you know the answer. Which anti-diabetic drug was recently approved in heart failure with low urine output? तो patient is having CKD, patient is having CHF. कौन से ड्रग है? Last year NEET PG question. Which anti-diabetic drug causes glycosuria and increase the risk of vulvovaginal, candida and bacterial UTI? Same answer, gliflozin. Same answer, gliflozin. Next question. Which anti-diabetic drugs is recently approved in the treatment of diabetic nephropathy? The answer is SGLT2 inhibitor. So gliflozin wale drug, they have been approved for diabetic nephropathy. But apart from this, there are other drugs also given in diabetic nephropathy because they have nephroprotective effect. We have ACE inhibitors. So they will end with the word pril. And the last drug, new drug, which I have already told you, finerenone. Finerenone was aldosterone blocker. So these are the three drugs which have been approved for diabetic nephropathy. Agreed? Because they have nephroprotective effect. Overall drug of choice, the first drug we always start is, remember, the first drug we always start is ACE inhibitor. So let's talk about diabetic gastroparesis. Treatment is metoclopramide. I hope you remember the word metoclopramide, which is now considered to be the drug of choice. You can also give one antibiotic, erythromycin. So erythromycin stimulates motilin receptor. Because it stimulates motilin receptor in GIT, it increases contractility of stomach given for diabetic gastroparesis. Diabetic retinopathy, we give anti-VEGF drug. VEGF word याद आ रहा है? Vascular endothelial growth factor. By inhibiting this, we can inhibit formation of new blood vessel, neovascularization. You just have to remember only one drug. Okay, although there are various drugs I have told you, but just remember one drug, bevacizumab. Although another drug is for INI-CET, ranibizumab, but try to remember bevacizumab. It is given as an intravitreal injection. How to remember bevacizumab? B means it inhibits the formation of blood vessel. तो ब्लड वेसल की फॉर्मेशन कौन इनहिबिट करता है? Bevacizumab. By inhibiting VE, it inhibits VEGF, vascular endothelial growth factor. It inhibits the formation of new blood vessels on retina, which can lead to bleeding and sudden blindness in diabetes. Diabetic neuropathy. Overall drug of choice is, last year MCQ, pregabalin. ठीक है, last year MCQ, pregabalin. This question we have already discussed. Pregabalin is the overall drug of choice for diabetic neuropathy. So which of the following listed medication aids in stimulation of bone formation? So which drug stimulates bone formation in the treatment of osteoporosis? Osteoporosis में कौन सा ड्रग बोन फॉर्मेशन करता है? ठीक है, कौन सा ड्रग बोन फॉर्मेशन करता? अरे बैंग, वेरी गुड, बैंग ऑन, वेरी गुड, ऑल आर एब्सोल्युटली राइट. So let's talk about drugs for osteoporosis. Remember, these drugs for osteoporosis, they increase BMD, bone mineral density, which you check by DEXA scan. So question will have DEXA scan. So how we can increase bone mineral density? Either you will inhibit the drug, inhibit a class of cells, osteoclast, or you will stimulate osteoblast. So the drug which will inhibit osteoclast, they will inhibit the destruction of bone, and the drug that stimulate osteoblast will promote bone formation. So which drug inhibit osteoclast? Remember a mnemonic B, C, D, E. Bisphosphonate, they are now considered to be the overall drug of choice for any type of osteoporosis, whether it is because of postmenopausal osteoporosis, it is corticosteroid induced osteoporosis, drug of choice is bisphosphonate. Then we have calcitonin, denosumab, and one drug raloxifene, which I will be telling you shortly. It is an SERM, selective estrogen receptor modulator. Now, which is the only drug that stimulates osteoblast and causes bone formation? So this drug will be anabolic drug. The drug name is teriparatide. Para word is coming, so it's a synthetic form of parathyroid hormone. It is the only drug which stimulates bone formation. So these two drugs are very commonly asked beta question. One question comes on bisphosphonate. Second is teriparatide. This question can be asked from pharma. This question can come in orthopedics as well. So first let's talk about, okay, before I'll come to this question again, let's talk about bisphosphonate. All these drugs, they will end with the word dronate. Alendronate, ibandronate, zolendronate. Zolendronate is the longest acting drug. It is given once a year injection. Now, bisphosphonate are the overall drug of choice for three conditions. HOP. It is the drug of choice for HOP. H for hypercalcemia, osteoporosis, any type of osteoporosis, and Paget's disease. Paget's disease of bone, not Paget's disease of breast. We are talking about osteoporosis. Now, what is the main side effect of bisphosphonate? Remember, the main side effect is ROSE. The side effect of bisphosphonate is ROSE. R for they produce, they can lead to renal failure. Bisphosphonate are contraindicated in renal failure. They can damage the bone of mandible. They can cause osteonecrosis of mandible, and they can lead to subtrochanteric femur fracture. Because of the risk of subtrochanteric femur fracture, bisphosphonate are never given beyond 10 years. क्योंकि 10 years के बाद किसका रिस्क इंक्रीज हो जाता है? What is the maximum duration we can give bisphosphonate? Up to 10 years, because beyond 10 years they can increase the risk of subtrochanteric femur fracture. Lastly, they are enemy of esophagus. They can damage esophagus, so they can cause esophagitis or reflux esophagitis. Then we have teriparatide. Teriparatide is synthetic form of parathyroid hormone. But remember how we give teriparatide? We give teriparatide like in this fashion. So it is given as a pulsatile or intermittent injection. Pulsatile or intermittent injections are given. Why injection? Tide word is coming. Because pulsatile or intermittent injection, parathyroid hormone stimulates osteoblast. Now remember where teriparatide is given. Remember, teriparatide is given in osteoporosis. It is absolutely contraindicated in hypercalcemia. It is absolutely contraindicated in Paget's disease of bone. So let's see the side effect. The side effect, it can lead to tumor of osteoblast. Because it is stimulating osteoblast, it can lead to osteosarcoma. Because of the risk of osteosarcoma, it is never given beyond 2 years. तो टेरीपैराटाइड मैक्सिमम कब तक दिया जाता है? टेरीपैराटाइड मैक्सिमम 2 साल तक दिया जाता है। बिसफॉस्फोनेट मैक्सिमम 10 साल तक दे सकते हैं। बियॉन्ड 2 years रिस्क ऑफ ऑस्टियोसार्कोमा, बियॉन्ड 10 years subtrochanteric femur fracture. Now two monoclonal antibody given in osteoporosis, how to identify? सर दोनों में OS वर्ड आ रहा है, दोनों में OS वर्ड आ रहा है। So these are the two monoclonal antibody approved for the treatment of osteoporosis. Osteoporosis में denosumab, romosozumab. Denosumab, it inhibit osteoclast. Why? It block rank receptor. It block rank receptor. Romosozumab stimulate osteoblast. It stimulate osteoblast. Remember one rule, all monoclonal antibodies are safe in renal failure. So it is renal safe, that is why we give. All monoclonal antibodies are safe in renal failure. Bisphosphonates are contraindicated in renal failure. Now tell me the answer of this question. Which of the following adverse effect prevents the use of teriparatide in a patient of Paget's disease? That is why Paget's disease में हम teriparatide नहीं देते. बताओ आंसर क्या है इसका? This question came last year in NEET exam. ये पिछले साल का सवाल है. Yes, the answer is. बच्चे ये वाला मार्क कराए थे. फर्स्ट वाला नहीं है बेटा. आंसर इज बी. Osteonecrosis of jawbone or mandible is a side effect not of teriparatide. It's a side effect of bisphosphonate. Now, which of the following drugs are given in thyroid storm except? This question came. थायराइड स्टॉर्म में कौन सा ड्रग नहीं देते? रिमेंबर थायराइड स्टॉर्म में हम एस्पिरिन नहीं देते. नाउ द ड्रग्स विच आर गिवन इन थायराइड स्टॉर्म आर पीपीआईडी. 4 ड्रग देते हैं, ठीक है? ओके, डोंट वरी, आई एम डिस्कसिंग ऑल द पीवाईक्यूज. मैं सारे पीवाईक्यू डिस्कस कर रहा हूं पिछले 3 से 4 साल के. ओके, तो पीपीआईडीज, so this is PPID. So the overall drug of choice for thyroid storm is propranolol. So the first drug to be started in thyroid storm is propranolol. Then we give propylthiouracil. Then we give iodides. Then we give dexamethasone. Remember, these drugs are given in the treatment of thyroid storm, and these drugs they also inhibit peripheral T4 to T3 conversion by inhibiting one enzyme, 5-deiodinase enzyme. 5-deiodinase convert T4 into active form, that is T3 form. So यही 4 drug PPID they inhibit. A G2P1 delivered a preterm baby at 36 weeks. Unfortunately, the baby did not survive. What is the drug given to reduce milk production in the mother? कौन सा ड्रग? Yes, some INI-CET PYQ I have also included. So the answer is cabergoline, because cabergoline is dopamine agonist. Because it is a dopamine agonist, remember, dopamine decrease prolactin production from pituitary. Because it reduces prolactin production, that is why it is given to reduce milk production after neonatal death. So after neonatal death, we can give dopamine agonist cabergoline by reducing prolactin production. Let's talk about very important topic, certain pituitary tumors. So remember, in pituitary tumors, we have prolactinoma. The first treatment of prolactinoma is drugs. The drugs which we give is dopamine D2 receptor agonist, because dopamine decreases prolactin production, and the overall drug of choice is cabergoline. Overall drug of choice is cabergoline, but in pregnancy, prolactinoma in pregnancy, we prefer to give bromocriptine. Prolactinoma in pregnancy, we prefer to give bromocriptine. If this treatment fails, then the second treatment is surgery. By surgery, transsphenoidal pituitary removal surgery, you will learn. But what about acromegaly? Acromegaly means growth hormone excess. In acromegaly, the first treatment is surgery, that is transsphenoidal pituitary removal. But if surgery fails and let's say there is incomplete removal of pituitary, then the second treatment is drugs. Then the second treatment is drugs, and the drugs which we give is somatostatins. The drug we give is somatostatin, and somatostatin drug, they will end with the word reotide, like octreotide. Agreed? Lanreotide. Lanreotide is a longer acting drug. That is why we can prefer. If it is still fails, the third treatment is give a drug pegvisomant. Give a drug pegvisomant. Pegvisomant is a growth hormone receptor. ANT word is coming, so it's an antagonist. So this is the treatment of prolactinoma and this is the treatment of acromegaly. So now we can have a break. Okay. Now we can have break. We'll have 5 minutes break. Fine. So welcome back everyone. One student is asking, beta class कब खत्म होगी? 9 बजे होगी बेटा. 9. At 9 the class will get over. Are you comfortable with that? So let's start with CNS. Okay, let's start with CNS now. I hope you all have joined back. Yes or no? I need the thumbs up. Thumbs up चाहिए अगर आप आ गए हैं, join कर लिया है तो. That's great. Great, great. I hope you are enjoying the session. So we are completing such a big topic, pharmacology. Within 5-6 hours we are. Yes, beta. Yes, you will get the PDF. This is all for you. It is not for me. What I am writing is only for you students only. ये आप ही को मिलेगा और किसी को नहीं मिलेगा. आप पढ़ जाओगे, फार्मा हो जाएगी. Okay? So let's start with. That's great. That's great. Let's join. Let's start with. चलो. Which drug is not used in ethylene glycol and methanol poisoning? Remember, these are harmful alcohol, toxic alcohols. So which drug is not used? Remember, disulfiram is not used. Disulfiram is rather given in ethanol. So we give sodium bicarbonate. Overall antidote is omeprazole, and we also give ethanol. So let's talk about poisonous alcohol, methanol. It first goes to the liver. There is an enzyme, alcohol dehydrogenase, which converts them into aldehydes. Then another enzyme is in liver, that is aldehyde dehydrogenase, which will convert them into respective acids. Remember, all these acids are highly neurotoxic. They are highly neurotoxic. They can lead to respiratory depression and they can also lead to blindness. But we know that in ethylene glycol poisoning, there is oxalate crystals in urine. This is a hint how you can identify or differentiate between methanol and ethylene glycol poisoning. Now remember, there is a drug which inhibits alcohol dehydrogenase enzyme. In alcohol, O word is coming. This drug also, O word will come, omeprazole. So omeprazole, O word is coming, O word is coming. So it is the overall antidote of, ethylene glycol and methanol poisoning, but it's an orphan drug. That means it's a very rare indication. Another drug we have is aldehyde dehydrogenase. In aldehyde dehydrogenase, remember D word is coming. The drug which inhibit is disulfiram. In disulfiram also D word is coming. So you can easily identify aldehyde disulfiram. Now let's talk about the question of this. Yes, aldehyde is not given. Disulfiram is not given. Now, a chronic alcoholic patient, alcohol means always and always ethanol. After stopping the intake of alcohol, develops body tremors, vomiting, visual and auditory hallucination. Which of the following drug is given to prevent another episode of these symptoms? So can we say the patient is suffering from withdrawal symptom? So which drug is given to prevent another attack of withdrawal symptom, that is chlordiazepoxide? Let's talk about alcohol de-addiction. So if a patient comes to you with acute withdrawal is an emergency. The patient become excitable, which is known as delirium tremens. Let's sedate the patient. Let's calm down the patient by giving IV diazepam. Now, after you have taken out the patient from this acute withdrawal, now we have to prevent another withdrawal. So now we maintain the patient on long-term maintenance phase to prevent withdrawal. We give oral chlordiazepoxide. The name is very much similar to diazepam only. And we slowly and slowly taper off this drug so that patient does not go into withdrawal symptom. But these two benzodiazepines, they are contraindicated in liver disease. So if the patient is having liver disease, let's say the patient is having raised AST and ALT levels, then instead of diazepam or instead of chlordiazepoxide, we give the drug lorazepam or oxazepam, because lorazepam and oxazepam are liver safe drug. Okay, so in liver failure, don't give diazepam and chlordiazepoxide. Now slowly and slowly you have tapered off the drug. Now the patient is alcohol free. Now the patient should not start drinking again. To prevent relapse or to maintain abstinence, we give anti-craving drug. In anti-craving drug, we give a combination of naltrexone with acamprosate. So they are given to prevent relapse so that patient should not start drinking again. But we have a drug that will induce fear or deterrent drug so that person should not start drinking again. The drug name is disulfiram. So here the drug we give is disulfiram. Now remember, is there any drug which is off-label use? Off-label means the drug which is not approved but found to be effective. Off-label anti-craving drug is one anti-epileptic drug, topiramate. And off-label deterrent drug we have is one antibiotic, metronidazole. So metronidazole is off-label use as a deterrent drug because I will be telling you metronidazole shows disulfiram-like reaction. Yes, but it is not approved, it is off-label use. The drugs which are approved I have written in black. Now what is disulfiram? We know that disulfiram inhibit aldehyde dehydrogenase. So because of this reason, when you give disulfiram, acetaldehyde accumulates in the body and acetaldehyde produce harmful symptoms. So that is why the patient will have fear that if I will drink alcohol, दारू मजा नहीं देगी, दारू सजा बन जाएगी, इसलिए डाइसल्फिराम दारू को सजा बना देता है, डेटरेंट ड्रग है. तो हार्मफुल सिम्टम्स लाइक वॉमिटिंग, फ्लशिंग, चेस्ट पेन, हाइपोटेंशन या डेथ भी हो सकती है. बिकॉज ऑफ दिस रीजन डाइसल्फिराम इज ओनली गिवन टू प्रिवेंट रिलैप्स, ताकि आदमी दोबारा शुरू ना करे. डाइसल्फिराम इज एब्सोल्युटली अवॉइडेड और कॉन्ट्राइंडिकेटेड इन एक्टिव ड्रिंकर्स. एक्टिव ड्रिंकर्स में बिल्कुल भी डाइसल्फिराम नहीं देना, क्योंकि पेशेंट की हाइपोटेंशन से डेथ भी हो सकती है. So that is why there are certain drugs which show disulfiram like reaction. That is why the drug which show disulfiram like reaction are absolutely contraindicated in active drinkers. Mnemonic is cyclic GMP. इसमें आपको दो ड्रग याद रखने हैं बेटा. पहला सीफोपराजोन और दूसरा आपने कौन सा ड्रग याद रखना है? मेट्रोनिडाजोल. अदर टू ड्रग्स आर ग्रेसियोफल्विन, ड्रग फॉर फंगल इन्फेक्शन, and we have procarbazine. Carvard it's an anti-cancer drug. Now the point is कैसे याद करें? कैसे याद करें? सर जब आप ओपेरा सुनने जाते हो, म्यूजिक सुनते हो, तो हाथ में क्या होता है? हाथ में दारू का गिलास होता है. तो ओपेरा वाला ड्रग अल्कोहल के साथ नहीं देना. तो ओपेरा सुनने जाओगे, सीफोपराजोन में ओपेरा वर्ड आ रहा है, तो हमें ओपेरा सुनेंगे, म्यूजिक सुनेंगे तो दारू नहीं पिएंगे. सेकंड इज जो लोग मेट्रो में होते हैं, मेट्रो सिटीज में होते हैं, वो ज्यादा दारू पीते हैं, तो मेट्रो वाला ड्रग दारू नहीं देनी इसके साथ. रिमेंबर दिस पार्ट. नाउ लेट्स टॉक अबाउट अनदर डी एडिक्शन, ओपियोइड या मॉर्फिन एडिक्शन. अगर एक पेशेंट को एक्यूट पॉइजनिंग है तो पेशेंट को क्या होता है? मियोसिस या पिन पॉइंट प्यूपिल. पेशेंट की डेथ होती है बिकॉज ऑफ रेस्पिरेटरी डिप्रेशन. तो एंटीडोट ऑफ ओपियोइड पॉइजनिंग इज आईवी नैलोक्सोन. अब आपने पेशेंट को बाहर निकाल दिया. अब अगेन वी विल पुट द पेशेंट ऑन मेंटेनेंस फेज टू प्रिवेंट अनदर अटैक ऑफ विड्रॉवल. 3 drugs are approved. These drugs are opioids. So 3 drugs opioid, they are given to prevent opioid withdrawal symptom. BMT, bone marrow transplant. B for buprenorphine, M for methadone एंड T फॉर ट्रामाडोल. ये 3 ड्रग अप्रूव्ड है टू प्रिवेंट ओपियोइड विड्रॉवल सिम्टम. और इन ड्रग को भी हम धीरे धीरे क्या करेंगे? टेपर ऑफ कर देंगे, ताकि आदमी नशा मुक्त हो जाए. अभी आदमी दोस्त की पार्टी में गया, दोबारा ओपियोइड लेना शुरू कर सकता है. सो वी हैव टू प्रिवेंट रिलैप्स, ताकि आदमी दूर रहे, दोबारा शुरू ना करे. हियर वी गिव ओरल नैल्ट्रिक्सोन. तो आई होप आपको समझ आ गया ओरल नैल्ट्रिक्सोन कहाँ यूज करते हैं और आईवी नैलोक्सोन कहाँ यूज करते हैं. आईवी नैलोक्सोन हम देते हैं बेटा एक्यूट पॉइजनिंग में. ओरल नैल्ट्रिक्सोन हम देते हैं टू प्रिवेंट रिलैप्स. नाउ लेट्स टॉक अबाउट अपार्ट फ्रॉम म्यू ओपियोइड रिसेप्टर, on which other receptor tramadol acts. So tramadol also has SNRI like property. It has serotonin, norepinephrine, reuptake inhibiting property. Let's talk about unique opioid. So tramadol is mu agonist, mu एक opioid receptor है, plus SNRI like property. Then we have methadone. Methadone is mu agonist, plus it has NMDA antagonist property. Because of its NMDA antagonist property, कौन सा ड्रग QT प्रोलोंगेशन करेगा? बिल्कुल मिलेगी बेटा पीडीएफ. लास्ट ईयर नीट क्वेश्चन. Methadone causes QT prolongation on heart. Pethidine, again mu agonist, plus pethidine has anticholinergic action. It has anticholinergic action just like a drug atropine. Just like a drug atropine. Pethidine के साथ लिखोगे 2P. It is the drug of choice in pregnancy. Pregnancy में opioid में कौन सा drug of choice है? Pethidine. It is also the drug of choice for post anesthetic shivering. पोस्ट एनेस्थेटिक शिवरिंग का भी ड्रग ऑफ चॉइस क्या है? पैथिडीन. सुफेंटानिल लिखेंगे मोस्ट पोटेंट ओपियोइड. फेंटानिल नॉट गिवन ओरली. हमने रीजन पढ़ा था, इट हैज अ वेरी हाई फर्स्ट पास मेटाबॉलिज्म इन लिवर. तो फर्स्ट पास मेटाबॉलिज्म एफपीएम किसका सबसे ज्यादा होता है? फेंटानिल का. रेमीफेंटानिल हमने पढ़ा था शॉर्टेस्ट ओपियोइड. पहले दिन it was metabolized or degraded by plasma esterase enzyme just like a beta blocker, that is ismolol की तरह. Let's talk about a disease, Wilson disease. Wilson disease में क्या होता है? बॉडी में कॉपर डिपोजिशन हो जाता है क्योंकि सेरिलोप्लाज्मिन जो कॉपर चिलेटर है इसकी डेफिशिएंसी होती है, तो लिवर और ब्रेन डैमेज हो जाता है. So that is why treatment of Wilson disease is overall drug of choice is zinc. Because zinc reduces copper absorption from GIT. अगर जिंक से ठीक नहीं होता, we add copper chelator. और बेटा आपको 2 कॉपर चिलेटर के नाम याद रखने हैं. पहला पेनिसिलामीन जो हमने र्यूमेटॉइड आर्थराइटिस में भी पढ़ा था, और सेकंड आपने याद रखना है ट्रायंटीन. ट्रायंटीन. देन वी हैव रेट सिंड्रोम. एक फीमेल है, मेंटल रिटार्डेशन. The only approved drug for Rett syndrome is trofinetide. तो trofinetide क्या है बेटा? It is IGF-1, insulin-like growth factor 1. It has neuroprotective effect in Rett syndrome. Rett syndrome is a neurodegenerative disease. ये neurons को protect करता है. Then we have amyotrophic lateral sclerosis. Sir Stephen Hawkins, who discovered black hole, he suffered from this disease. So remember 3 drugs in amyotrophic lateral sclerosis. L for riluzole, which is NMDA antagonist. Second is edaravone. So first 2 drugs have been asked in your exam. Third drug is tofersen. So these are neuroprotective drugs. Then we have multiple sclerosis in which there is myelin sheath damage because of autoimmune or antibodies. They damage myelin sheath in brain. The first type of multiple sclerosis is RRMS, relapsing remitting multiple sclerosis. The drug of choice is interferon beta. Plus we add all other drugs to interferon beta like natalizumab, glatiramar. Agreed? Then we have SPMS. SPMS is secondary progressive multiple sclerosis. Here the drug of choice is most effective is mitoxantron. And after mitoxantron, we can add other drugs. Now we have the most dangerous one, PPMS, which stands for primary progressive multiple sclerosis. Here the drug of choice is ocrelizumab, which was asked previous year in NEET exam. It is the only drug approved for. It is the only drug we have for PPMS, primary progressive multiple sclerosis. Primary progressive multiple sclerosis, natalizumab, it has a side effect of JC polyoma virus infection happens. It can lead to JC polyoma virus infection. It causes one disease known as PMLE. PMLE stand for progressive multifocal leukoencephalopathy. The white matter of the brain becomes destroyed. Now, what is the drug of choice for certain motor disorder? Restless leg syndrome. Now, the drug of choice has become pregabalin or gabapentin. Sydenham's chorea. The drug of choice is valproate. Huntington's chorea. The drug of choice is dopamine depleters, because Huntington's chorea occur because of excessive dopamine. These drugs, they will end with the word benazine, tetrabenazine, valbenazine. Then we have Tourette syndrome. Here the drug of choice is alpha 2 agonist. The drug is clonidine or guanfacine. Clonidine and guanfacine. Now remember, in resistant cases of Sydenham's chorea, in resistant cases of Huntington's chorea, in resistant cases of Tourette syndrome, we give a drug antipsychotics. We give a class of drug antipsychotics like haloperidol, risperidone, etc. So we give antipsychotic drug in resistant cases of all these agents. Now tell me the answer. Which of the following are drug used for absence seizure? So in absence seizure, we only use three drug EVL. EVL. So can you tell me which drug is starting with the word E and V? That is valproate, ethosuximide. So the answer is B and C only. B and C only. So let's talk about all the drug of choice for epilepsy. The first epilepsy is GTCS, that is generalized tonic-clonic seizure, also known as grand mal epilepsy and major epilepsy. Here the first line drug is V and L. V for valproate or L for lamotrigine. But if the patient is having absence seizure is also known as petit mal epilepsy. There is no body movement, absence of body movement. That is why it is only diagnosed on the basis of EEG, 3 Hz wave spike pattern. Here the drug of choice is EVL. E stands for ethosuximide. And second drug is valproate. Third drug is again lamotrigine, because all these drugs, they block T type of calcium channel. T type of calcium channel leads to absence seizure, because T type of calcium channels are present in thalamus. Thalamus neurons, when they fire, it leads to absence seizures. Then rest all other generalized seizure, we give VLT. Can you tell me V and L we already know? T stands for topiramate. So topiramate is the first line drug for atypical absence, myoclonic, atonic and tonic seizures. So these are the first line drug. Now let's talk about febrile seizure. Febrile seizure occurs because of fever in children. The drug of choice is rectal diazepam. But another drug which has been approved is intranasal. This has been asked as an MCQ, midazolam. Intranasal midazolam can also be given. Infantile spasm, which is also known as West syndrome. Here we give a drug ACTH hormone. But if this infantile spasm occurs with tuberous sclerosis, here we give a drug vigabatrin. Here we give a drug vigabatrin. In Lennox-Gastaut syndrome and Dravet syndrome, the patient has myoclonic seizure. So in myoclonic seizures, we can give VLT, VLT. So can you tell me what does T here stands for? What does T here stands for? T stands for topiramate. So question came, is topiramate approved for Lennox-Gastaut syndrome? The answer was yes, because myoclonic seizure we have discussed. So it is given for Lennox-Gastaut syndrome. So we can give any of the following drug. In resistant cases of Lennox-Gastaut, we have a drug felbamate. In resistant cases of Dravet syndrome, we have a new drug stiripentol. And last year, INI-CET question, another drug recently got approved for 3 types of seizure. Which 3 seizure? infantile spasm with tuberous sclerosis, Lennox-Gastaut syndrome, and Dravet syndrome. Which drug is approved for all three syndrome? The drug name is cannabidiol. Last year, INI-CET MCQ, cannabidiol, cannabinoid, they are given for infantile spasm with tuberous sclerosis, Lennox-Gastaut syndrome, and Dravet syndrome. Remember this point. Now, what is the disadvantage of oxcarbazepine over carbamazepine? Let me tell you one point. Oxcarbazepine, it is contraindicated in old age, while carbamazepine is contraindicated in children. We can easily remember. Old age, oxcarbazepine नहीं देना, carbamazepine children में नहीं देना, because oxcarbazepine has more risk of causing SIADH. Excessive ADH will lead to hyponatremia. And in children, we apply Johnson & Johnson baby powder. Carbamazepine in children carries a risk of Stevens-Johnson syndrome. It carries a risk of Stevens-Johnson syndrome. Now tell me the answer of this question. Yes, you all are absolutely right. This was the last year's question. So because of the risk of hyponatremia, we don't give oxcarbazepine in old age. Next question, last year's INI-CET question. For which drug increase the amount of GABA by inhibiting degradation of GABA? So which drug inhibit GABA transaminase enzyme? The drug which inhibit GABA transaminase enzyme is vigabatrin. How we can remember? GABA, GABA. TR means transaminase. TR means transaminase inhibitor in. So GABA transaminase inhibitor is vigabatrin. But there is a drug which will inhibit both enzyme, GABA transaminase and SSD enzyme. The drug is valproate. Valproate inhibit both enzyme, the GABA transaminase enzyme as well as succinate semi-aldehyde dehydrogenase enzyme. Now tell me the answer of this question. The answer of this question is valproate. So vigabatrin is a GABA transaminase inhibitor. What is the main side effect of vigabatrin? VI word is remaining. So vigabatrin causes visual field defects. This will be the side effect of vigabatrin. The name vigabatrin itself will tell you everything. Vigabatrin. Now let's talk about next question. So which drug increase the release of GABA? That is pregabalin and gabapentin. Now which drug can directly stimulate GABA receptor? That is barbiturate and benzodiazepine like diazepam, etc. Benzodiazepines, they act on alpha gamma subunit of GABA A receptor. Then we have the drug which inhibit GABA transaminase, vigabatrin and valproate. Vigabatrin and valproate, they inhibit GABA transaminase enzyme, inhibit degradation of GABA. Now which drug inhibit reuptake of GABA? Reuptake of GABA is by a transporter, GAT transporter. The drug name is tiagabine. Last year MCQ. How we can remember? It is a transporter inhibitor of GABA. So how we can remember? T for transporter, I for inhibitor, and GABA word is coming. Tiagabine inhibit reuptake of GABA because it is a GABA transporter inhibitor. Now, which drug causes visual disturbance and contraction of visual field? So we know the answer, vigabatrin. The answer is vigabatrin. Now, which anti-epileptic drug has been approved as a weight loss medication? Anti-obesity drug. Its also have one carbonic anhydrase inhibiting property, just like acetazolamide. Its main side effect is angle closure glaucoma, and second side effect is renal stone. So which anti-epileptic drug I am talking about? I am talking about topiramate. And another drug is zonisamide. But what you have to remember is topiramate. Topiramate is very important. You must remember this point. Okay? Now, which anti-epileptic drugs are given for the treatment of neuropathic pain? So first, let me tell you the treatment of neuropathic pain. Then you can easily solve this question. What is the drug of choice for trigeminal neuralgia? Carbamazepine. Fine. Post-herpetic neuralgia. Either you can give pregabalin or you can give gabapentin as a drug of choice. And diabetic neuropathy, we have just discussed, the drug of choice was pregabalin. So pregabalin, lamotrigine, gabapentin, 1, 2 and 4. So 1, 2 and 4 is option number B. So these are the drug of choice. Now a patient of schizophrenia treated with clozapine, for which rare idiosyncratic means dose independent side effect. It can occur at any dose, but serious side effect should be monitored. Remember, clozapine के साथ closely monitor WBC count, because it leads to fall in WBC count, which leads to agranulocytosis. So agranulocytosis is the main side effect of clozapine. So let's talk about clozapine side effect. So clozapine non-serious side effect is HOTS. It causes hypersalivation. It causes obesity. But remember, maximum obesity is by a drug olanzapine. Maximum obesity is caused by olanzapine. It can increase the risk of diabetes and sedation. The serious side effects are SAM. And among SAM, seizure, agranulocytosis and myocarditis. Agranulocytosis means bone marrow suppression. So there will be fall in WBC. And this agranulocytosis is the dose independent side effect of clozapine. Dose independent side effect of clozapine is agranulocytosis. It can occur at any dose. So maximum obesity is caused by which antipsychotic drug? Olanzapine. You will write least risk of weight gain. Least risk of weight gain is by which antipsychotic drug? Last year MCQ. First alphabet A, last alphabet Z. A for aripiprazole. Aripiprazole, and the last alphabet is Z, ziprasidone. They will have least effect on weight gain. Maximum obesity is by olanzapine. Now for the treatment of olanzapine induced obesity. So for the treatment of obesity due to olanzapine, we have made a new drug. That new drug is samidorphan. A samidorphan is a new drug which is specifically approved for the treatment of olanzapine-induced obesity. This drug got approved last year in 2024. Agree? Now, which of the following is true about lithium? It causes fine tremors at therapeutic dose. True. It is not absorbed from GIT. False. It is given for absence seizure treatment. No, it is given for BPD, bipolar disorder. It is not teratogenic. False. Agreed? So let's talk about all the points related to lithium. Lithium is an important drug. So first use of lithium is it is given in bipolar disorder. Lithium also reduces the risk of suicide. It's an anti-suicidal drug, lithium. Another drug which has anti-suicidal property is clozapine. Lithium and clozapine reduce the risk of suicide. So with salt of lithium we give in bipolar disorder, we give lithium citrate or carbonate. And remember, lithium is same like sodium if you remember chemistry. Sodium is absorbed orally, lithium will be absorbed orally. In fact, it is 100% absorbed when given orally. So that is why it is given orally and as well as IV. The half-life of lithium is 1 day. How we can remember? It is the first metal in periodic table. Half-life is 1 day and blood sample is taken 12 hours after the dose of lithium. So when we give lithium at night, we take the blood sample of lithium in the morning because lithium requires monitoring. Agreed? So maintenance of bipolar disorder 0.5 to 1, 1 to 1.5 acute mania में देते हैं. But if the level is more than 1.5 in blood, it indicates toxicity. And if the level is more than 4, it's an indication to start hemodialysis. So what is the treatment or antidote of lithium? Logical antidote of lithium should be sodium, because sodium is the big brother of lithium. Sodium will remove this lithium into the urine. So hydration with saline or sodium chloride, and in them we can add 2 diuretic which will help in removal of lithium into the urine. Along with sodium we can give mannitol and amiloride. Agreed? हाँ बेटा 0.6 था, बिल्कुल सही बात है. Just to make it simple so that you can remember 0.5 to 1, 1 to 1.5. So it becomes very patterned, है ना? Easy हो जाएगा ना आपके लिए याद करना. Don't worry, इतना close कोई नहीं पूछने वाला. Adverse effect of lithium is lithiums. So remember, clozapine was causing decrease in WBC. Lithium causes increase in WBC. So this is a point you must remember. Clozapine reduced WBC. Lithium causes leukocytosis, increase in WBC. Now lithium causes tremor in normal dose, fine tremors. In toxic dose, coarse tremors. In toxic dose, coarse tremors. Now lithium causes hypothyroid goiter, important. Lithium causes nephrogenic diabetes insipidus, excessive urination. And in mental, it can cause ataxia, tinnitus and seizure. Is lithium teratogenic? Yes, lithium causes Epstein anomaly. It's a cardiac anomaly which we have discussed yesterday. Abnormal tricuspid valve, box-shaped heart. Epstein anomaly is a teratogenic effect of lithium, box-shaped heart. Next point, a bank employee suffering from depression. He came to AIIMS OPD. He was started on S-citalopram. S-citalopram is an SSRI which I am going to tell you. Which of the following adverse effect cannot be explained by S-citalopram? So which of the following is not the side effect of S-citalopram? Okay. So lithium dose must be reduced in third trimester of pregnancy. Dose must be reduced. So remember the answer is Cialorrhea. Instead of Cialorrhea, SSRI they rather produce dry eyes and dry mouth. Okay? Their most common side effect is nausea. Their characteristic side effect is sexual dysfunction, that is anorgasmia. So let's talk about all antidepressant drug at one place. So first is SSRI. The names are very important. FFP Dex. That is fluvoxetine, fluvoxamine, paroxetine, depoxetine, escitalopram, citalopram and sertraline. You have to remember fluvoxetine overall is the longest antidepressant drug. Because it is the longest acting antidepressant drug, it will have least risk of causing drug discontinuation syndrome. So that means if you will suddenly stop them, nothing will happen. Then we have SNRI, serotonin norepinephrine reuptake inhibitor. So that is venlafaxine, milnacipran, duloxetine. Venlafaxine is the shortest acting drug. It will have maximum risk of causing drug discontinuation syndrome. Duloxetine, you can see D and U word is coming. Duloxetine, D and U word is coming. Duloxetine has been approved for diabetic neuropathy. And U for urinary incontinence. It is also approved for which type of urinary incontinence? Stress urinary incontinence. Okay. Next point is NRI, norepinephrine reuptake inhibitor. The drug is atomoxetine. Yesterday I told you atomoxetine A and T word is coming. So it is a drug of choice for ADHD with Tourette syndrome. If ADHD occurs with Tourette syndrome, we give NRI. Now all these antidepressants, their side effect is common, antidepressant side effect. So all the secretions are reduced, dry eyes and dry mouth. Scissors, suicide. Why suicide? If you suddenly stop them. If you suddenly stop them, it increases the risk of suicide, which is known as drug discontinuation syndrome. That is why certain Hollywood, Bollywood people you must have seen, Sushant Singh Rajput and everything, they were taking antidepressant which can lead to paradoxical suicide. And their side effect is sexual dysfunction. In sexual dysfunction, they can cause delayed ejaculation. Because they produce delayed ejaculation, SSRI are the drug of choice for the treatment of premature ejaculation. So in premature ejaculation, you can remember one drug, we give paroxetine. Because it causes delayed ejaculation given in the treatment of premature ejaculation. Now all antidepressant when given in pregnancy, in fetus they can cause PAH. Their teratogenic effect in fetus is pulmonary artery hypertension. Pulmonary artery hypertension. Ramchandra ji, you are in 11th biology stream. Why you are here? But anyway, if you are here, just have a glimpse that बेटा लोग बोलते हैं ना एक बार MBBS कर लो लाइफ सेट है. आपको बाकी बच्चे बताएंगे लाइफ कितनी सेट है. पहले से भी ज्यादा पढ़ना पड़ता है. A patient was treated on tricyclic antidepressant for major depressive episode, which is not seen with the TCA. Which is not seen with the TCA. TCA से कौन सा side effect नहीं देखा जाता? Anyone? This question came last year in NEET PG. Which of the following is not the side effect of TCA poisoning? Anyone? The answer is hypothermia. So I will tell you, it rather produce hyperthermia. Let's see the reason why. So let's talk about tricyclic antidepressant. They will end with the word pramine. They will end with the word pramine. Imipramine, desimipramine, clomipramine, trimipramine. They will end with the word triptyline, amitriptyline, nortriptyline. And try to remember 4 drugs more, dard. That is doxepin, amoxapine, reboxetine, and dothepin. What is the main action of tricyclic antidepressant? Tricyclic antidepressant are also SNRI, serotonin, norepinephrine reuptake inhibitor. But remember, they are non-selective drug. They block many receptors, unwanted receptors in the body. So if they block histamine receptor, the first side effect of tricyclic antidepressant is sedation. Because they block acetylcholine receptors, muscarinic receptor, they produce atropine-like side effect. And yesterday we discussed atropine produce hyperthermia. Atropine produce hyperthermia, not hypothermia, mydriasis, and urinary retention. Because they block alpha receptor, they can lead to hypotension. And because they block potassium channel on heart, they can lead to QT prolongation. So these are the side effects of TCA. So what is the antidote of TCA poisoning? Beta, we have discussed yesterday. The antidote of tricyclic antidepressant poisoning or imipramine poisoning is sodium bicarbonate. Okay, sodium bicarbonate. Next question, beta. Let's focus back. Let's focus back. Everyone focus back. A 35-year-old male patient presented to surgery emergency with painful erection. That is priapism. Painful penile erection is priapism from past 7 hours. He has a history of mood disorder, recently prescribed a medicine by treating psychiatrist. What is the most likely offending drug? Last year NEET question. तो कौन से ड्रग से ट्रेजेडी हो जाएगी? डोंट यू थिंक बहुत तगड़ी ट्रेजेडी है? प्रियापिज्म होना तो बहुत बड़ी ट्रेजेडी है. तो बताओ कौन सा ड्रग ट्रेजेडी वाला है? ट्रेजेडी किससे होती है? दैट इज प्रियापिज्म. दैट इज बाय ट्राजोडोन. ट्राजोडोन विल लीड टू tragedy. So let's talk about certain new or atypical antidepressant, very important for you. So first is bupropion. Bupropion is NDRI, norepinephrine dopamine reuptake inhibitor. So this antidepressant we have discussed in anti-smoking. It has also been approved as an anti-obesity drug. Its main side effect is seizures, which we discussed yesterday. Then we have trazodone. Advantage of trazodone is no risk of impotence or erectile dysfunction, but the side effect is tragedy. It can cause priapism. Metazapine and mianserine, they are sedative drug. So they are preferred in the treatment of depression with insomnia. Vortioxetine, vilazodone, they are new SSRI-like drugs. So you have to remember these drug names. SSRI-like drug, phenelzine, moclobemide, tranylcypromine. These drugs are MAO inhibitor, monoamine oxidase inhibitors. So these are monoamine oxidase inhibitor. You have to remember their names. It was asked recently the names of few MAO inhibitors. Fine. So we are finished with CNS. Let's talk about antimicrobials. In antimicrobial, the drugs which are cell wall inhibitors are beta-lactams. So beta-lactams, remember they inhibit transpeptidase enzyme. So we have penicillin, cephalosporin, carbapenems, and one drug aztreonam. Their main side effect is hypersensitivity or allergy. And they can cause all types of 1 to 4 hypersensitivity. Now, aztreonam, no cross allergy. It does not cause any cross allergy. All three drugs, they can cause cross allergy. In simple word, if a patient is allergic to penicillin, we should not give cephalosporin. We should not give carbapenems. What are the names of those drugs? I will be telling you. There is a trick to remember. But aztreonam can be given. So what is the drug of choice for penicillin allergy? The drug of choice for penicillin allergy is erythromycin or azithromycin. Another drug which is a cell wall inhibitor we have is vancomycin. So vancomycin inhibit an enzyme, trans-glycosylase enzyme. It inhibits trans-glycosylase enzyme. Now remember how we can remember. In micro you have written that cell wall of a bacteria is made up of peptidoglycan. Peptido part, glycan part. So peptidase, peptide part is inhibited by beta-lactam group and the glycan part is inhibited by a drug vancomycin. So peptidoglycan, peptides, beta-lactam, glycans, vancomycin. A new drug similar to vancomycin is teicoplanin. And all these drugs, why they are not effective in mycoplasma? All these drugs are not effective in mycoplasma, chlamydia and rickettsia. Which student will tell me the reason for it? Why penicillin, vancomycin are not effective in Mycoplasma, chlamydia? Because they are atypical bacteria, they lack cell wall. They don't have cell wall. Great. So now let's talk about treatment of certain infection. Syphilis caused by Treponema pallidum. The overall drug of choice is benzathine penicillin. Benzathine penicillin, it is the drug of choice for all stages of syphilis. It is the drug of choice for all stages of syphilis. We give by intramuscular except neurosyphilis. So in which syphilis we don't give benzathine penicillin? In neurosyphilis, we give aqueous penicillin. We give aqueous penicillin. So aqueous penicillin is either penicillin G or procaine penicillin. So they are given. Now syphilis in penicillin allergic patient. If the patient is penicillin allergic, the drug of choice is doxycycline. So syphilis in penicillin allergy, give doxycycline. Now meningococcal meningitis, the drug of choice for the treatment now has become third generation cephalosporin, injection of ceftriaxone. Ceftriaxone has become the drug of choice. And what is the drug of choice for prevention? Prophylaxis. Why? we have to give prophylaxis to kill nasal carrier state, because this harbors, it comes and goes into nose. The drug of choice is ciprofloxacin. Ciprofloxacin is the drug of choice, not rifampicin. Now the drug of choice is ciprofloxacin. Earlier the drug of choice was rifampicin, but now the drug of choice has become ciprofloxacin. But remember, okay, so drug of choice for treatment is ceftriaxone, prevention ciprofloxacin. A patient was taking ampicillin. Now the patient is experiencing diarrhea. So this is antibiotic associated diarrhea. This is known as Clostridium difficile diarrhea. Which drug is given to manage this condition? So any drug which is given for the treatment of Clostridium difficile diarrhea, very good beta. The drug is fidaxomicin. So let's talk about Clostridium difficile diarrhea, which is also known as antibiotic associated diarrhea. Antibiotics, they kill good bacteria in GIT. That is why this harmful bacteria grows and it leads to pseudomembranous colitis. So which antibiotic causes pseudomembranous colitis? That is CCAF, C for clindamycin. Overall, highest risk of causing Clostridium difficile diarrhea is by clindamycin. Other are cephalosporins, mainly third generation, ampicillin, and fluoroquinolone. These four antibiotics have highest risk of causing CCAF, that is Clostridium difficile diarrhea. What is the treatment? Treatment is give oral vancomycin. Remember here, oral vancomycin is, oral word is also very important. We give oral vancomycin. Then we have fidaxomicin. Remember, fidaxomicin is the most effective drug for the treatment of Clostridium difficile diarrhea. There is one monoclonal antibody, pezlotoxumab. So it is against toxin B of Clostridium difficile. It blocks toxin B. We can give metronidazole. Metronidazole, it is now not considered to be the drug of choice. It is only given as an add-on drug if there is sepsis, and we can replace good bacteria. We can do fecal transplant. So fecal transplant means replace good bacteria, and fecal transplantation is done in the treatment of pseudomembranous colitis. Now let's talk about a very important infection, Staph aureus. MSSA stand for methicillin sensitive Staph aureus. Now, methicillin sensitive Staph aureus, here the treatment is penicillinase resistant penicillin. These are condom. Agreed? These are condom. But now we have MRSA, that is methicillin resistant Staph aureus. Here the cause of mutation. What is the cause of resistance? There is mutation in transpeptidase enzyme. Anywhere we have discussed transpeptidase, which is also known as penicillin binding protein 2A. Because of this reason, suddenly all beta lactams which we have discussed, penicillin, cephalosporin, they become non-effective. All beta-lactam like penicillin, cephalosporins, carbapenems, aztreonam, which we have discussed, they are not effective. So what is the drug we have for MRSA? IV drugs. So overall, drug of choice for MRSA is vancomycin. Overall drug of choice for MRSA is vancomycin. But the story doesn't end here. Now it has been converted into VRSA. VRSA stand for vancomycin resistant Staph aureus. You give a drug linezolid. You give a drug linezolid. Another drug you can give is daptomycin. You can give fifth generation cephalosporin. And fifth generation cephalosporin, you have to identify ROL word like ceftaroline, ceftabiprole. Now, topical drug for MRSA. Topical drug for MRSA is mupirocin, very commonly asked question, mupirocin 2% cream. So topical drug for MRSA is mupirocin 2% cream. Mupirocin 2%. You can give any of the following drug. Daptomycin is the most effective drug for VRSA, but unfortunately daptomycin is not available in India. So in India we only start with linezolid. Okay. Now let's talk about Lischera. The drug of choice is ampicillin with gentamicin. Agreed? Then enterococcal endocarditis. Again the drug of choice is ampicillin with gentamicin. Now comes the question. In ampicillin, which is a penicillin, in ampicillin resistant cases or ampicillin allergic cases, we give IV, replace this ampicillin with vancomycin with gentamicin. Remember, in Clostridium difficile, vancomycin was given orally, while in this infection we give vancomycin IV. What is the main side effect of vancomycin? Vancomycin is ototoxic, it is nephrotoxic, and vancomycin causes red man syndrome. Red man syndrome is histamine release from mast cell, which leads to redness. Redness is the main side effect of vancomycin. Now tell me the answer of this question. Which drug is given to reduce toxin production in toxic shock syndrome? Toxic shock syndrome is due to super antigens of Staphylococcus and Streptococcus. Now in toxic shock syndrome, toxin to kill bacteria, any dangerous gram positive bacteria, straight away give vancomycin. But to reduce toxin production, which is the cause of death, we give a drug clindamycin. So clindamycin is given to reduce toxin production in toxic shock syndrome toxin. So here the answer is not vancomycin. Here the answer is clindamycin. Here the answer is beta clindamycin. So that is why this question has been asked 3-4 times in your NEET PG and INI-CET exam. Next question. A patient is having fever with eschar. What is the treatment? Fever with eschar. Yes, this is the treatment. This is the rickettsial infection. So in rickettsia beta, now the treatment of choice has become doxycycline with azithromycin, not doxycycline alone. Combination of doxycycline with azithromycin. Now I'll come to all this part. Let me now make your overview. How to mark a correct answer in exam. Remember, any gram negative community acquired infection which will spread between you and me easily. Let's say, don't you think typhoid spreads easily by food poisoning? Meningococci spreads by aerosols. Gonococci spreads by love-making sexual contract. H. influenza aerosol. Any gram negative community acquired infection, give third generation cephalosporin as the drug of choice. The drug of choice is third generation cephalosporin. So you can give injection of ceftriaxone, or you can give oral cefixime. So Zeme and Zone word is coming. They are considered to be the drug of choice. So can you tell me oral drug for typhoid? Oral drug for gonorrhea? The answer is cefixime. Injectable drug, you know. But in their resistant cases, which drug to be given? I will tell you shortly. In the resistant cases, we will give these drugs which I am going to tell you. Now let's talk about certain bacteria which we never hear normally, because these bacteria don't spread in community. They only produce hospital acquired infection or nosocomial infection. Like if a patient is on ventilator, ventilator associated pneumonia caused by Klebsiella and Acinetobacter. Similarly, when we put Foley's catheter, catheter associated urinary tract infection caused by Pseudomonas burkholderia. Sir, which drug to be given? Straight away start carbapenems. Straight away start carbapenems. And any drug which is a carbapenem, it will end with the word penem. It will end with the word penem. So heard about imipenem, meropenem. So they are given in hospital acquired gram negative infection. But nowadays, beta, what is happening? These bacteria are becoming resistant to carbapenems as well. One classical example of carbapenem resistant Klebsiella is Delhi superbug. One example of Klebsiella, which is one example of carbapenem resistant bacteria, is Acinetobacter baumannii. So in carbapenem resistant bacteria like Delhi superbug, we straight away start now colistin. So I hope now you have an overview which drug to be given in which type of bacteria. I hope you will not mark this dangerous question wrong in your exam now. Agreed? Now, which carbapenem is most toxic? Imipenem is the most toxic carbapenem. It causes nephrotoxicity and it causes seizure. Now, to reduce toxicity of imipenem, we combine imipenem with the drug cilastatin. So, cilastatin is combined with imipenem to reduce toxicity of imipenem. Okay? To reduce the toxicity of imipenem. Now, let's talk about DNA inhibitor. DNA inhibitor, we have metronidazole. So, these drugs, they will end with the word nidazole. Nidazole, nidazole, nidazole. So, where they are given? They are given in Gupta ji's giardiasis and Gardnerella infection. Gardnerella causes bacterial vaginosis. They are metronidazole is given in ulcer due to H. pylori. It is given for pseudomembranous colitis. It is given for Trichomonas vaginalis infection. It is also given for anaerobic bacteria and amoebic dysentery and amoebic liver abscess. The drug of choice is metronidazole. Now, how to identify? The question will come bacterial vaginosis. You will get a hint of clue cells. Clue cells. In Trichomonas vaginalis, you will get a hint of fishy smell of vaginal discharge. Fishy smell of vaginal discharge and strawberry cervix. Strawberry cervix. That will be a hint of Trichomonas vaginalis. So metronidazole, can you tell me its main drawback? If you are in metro, we know metro people, the people who live in metro, they drink a lot. We know metronidazole causes disulfiram-like reaction. Another DNA inhibitor, fluoroquinolone, they will end with the word floxacin. They inhibit DNA gyrase enzyme. And their classical side effect is tendinitis. Tendinitis means they can lead to rupture of Achilles tendon. They can also lead to photosensitivity on skin. They can also produce QT prolongation. So QT prolongation, photosensitivity and tendinitis. Protein synthesis inhibitor, tetracycline. We will see where doxycycline is used. Remember, doxycycline is the only tetracycline which is renal safe. Renal safe tetracycline is doxycycline. So minocycline is given in the treatment of acne and leprosy. Now remember, tetracycline, they chelate with calcium. Because they chelate with calcium, they produce tooth damage. They produce tooth damage and stunting. They produce stunting in children. That is why they are contraindicated in children less than 8 years of age. because of tooth damage and stunting. Then we have chloramphenicol. Remember 3B with chloramphenicol. Chloramphenicol brain entry is very good. It is given in the treatment of meningitis. Chloramphenicol causes bone marrow suppression and it is contraindicated in babies or neonates because chloramphenicol causes gray baby syndrome. Gray baby syndrome is caused by chloramphenicol. That is why it is contraindicated in babies or neonates. Macrolides, they will end with the word thromycin. A recently approved new drug in macrolide made in India drug is nephithromycin. Nephithromycin is made in India drug, recently got approved last year by Indian government. So let's talk about other drugs shortly. Linezolid. Linezolid means side effect you have to remember comb. Linezolid side effect is comb. But great advantage of linezolid, just like doxycycline, it is also renal safe. So it causes chorioretinitis, it causes optic neuritis, chorioretinitis and optic neuritis. That means it can lead to blindness. It can lead to blindness. Next is very important. Which antibiotic has MAO inhibiting action? Linezolid. And which antibiotic can cause bone marrow suppression? Linezolid. So linezolid we have discussed, it is given in the treatment of VRSA. It is also given in the treatment of VRE, vancomycin resistant enterococci, vancomycin resistant Staphylococcus aureus. Then we have aminoglycosides. Aminoglycoside, they will end with the word omycin. Okay? Or mycin word will come. Okay? Mycin or mycin word will come. So aminoglycoside, their main side effect you have to remember ototoxic, nephrotoxic, and they block NM receptor. NM receptor of acetylcholine it is blocked, and we discussed that is why it is contraindicated in myasthenia gravis. Myasthenia gravis. Now let's talk about treatment of specific infection. First is gonorrhea. So we know gonorrhea is a gram-negative bacteria spread in community. So you can give ceftriaxone or cefixime, third generation cephalosporin, along with azithromycin. The dose of azithromycin is 2 grams. Chlamydia, it causes trachoma and it causes a sexually transmitted disease LGV, lymphogranuloma venerum. Here we give doxycycline with azithromycin. Azithromycin 1 gram single dose. So if I'll ask you a question, if there is a mixed infection of chlamydia and gonorrhea, which single drug would you like to give? So if the patient is having chlamydia and gonorrhea, then give only azithromycin. It will cover both of them. And which dose of azithromycin you will give? You will give higher dose 2 grams of azithromycin. Again, rickettsia, doxycycline and azithromycin. Cholera, doxycycline. Now the point is doxycycline, it is contraindicated in pregnancy. Tetracyclines, they chelate with calcium. They are contraindicated in pregnancy. Here the drug of choice in all these infection is azithromycin. Azithromycin is the drug of choice for gonorrhea, chlamydia, rickettsia, cholera in pregnancy. Doxycycline is contraindicated. Diphtheria and pertussis, you can give erythromycin or you can give clarithromycin or you can give azithromycin. But the question which was asked recently in diphtheria and pertussis, remember erythromycin and clarithromycin are contraindicated in neonates because in neonate they can cause hypertrophic pyloric stenosis. So if I'll ask you a question, diphtheria or pertussis in 2-week-old neonate, this question came, pertussis in 2-week-old neonate. What is the drug of choice? The drug of choice will be azithromycin, because azithromycin does not produce hypertrophic pyloric stenosis. So then we have antifolate drug sulfonamide, okay? And we have a drug dapsone. Now when this sulfonamide is combined with pyrimethamine, this combination is given for toxoplasma. But if this toxoplasma occurs in pregnancy, add spiramycin. Agreed? Now sulfonamide, when it is combined with, let's say, sulfamethoxazole, when it is combined with trimethoprim in the ratio 5:1, this combination is cotrimoxazole. And cotrimoxazole, drug of choice for pneumocystis, Jerovicai infection. Pneumocystis, Jerovicai infection, 5:1. Dapsone I will be telling you shortly in leprosy. Yes, other infections also, just remember pneumocystis. Match the following bacteria with their drug of choice. I hope now you can answer this INI-CET question which was asked previous year. Because of this question, I have taught you so much antimicrobial. So try to answer. Bacterial vaginosis, Trichomonas vaginalis, metronidazole. Very good. MRSA beta, vancomycin. 2 का A, ठीक है? B का 1. Typhoid meningococci, gram negative community acquired infection, ceftriaxone. So ceftriaxone. Klebsiella, hospital acquired infection, ventilator associated pneumonia, give carbapenems, D ka 3. So I hope now you can see the answer A ka 2. This will be correct. Now drugs for malaria. So malaria, female anopheline mosquito. For sporozoite we don't have any drug, but for sporozoite we have a vaccine. The vaccine name is Mosquirix. Now for hepatic schizophrenia, the most effective drug is primaquine. Agreed? For hypnozoid, which you call it as a radical cure, the most effective drug we have is primaquine, but a new drug recently got approved is tafenoquine. That is for radical cure or hypnozoid. For gametes, again the most effective drug we have is primaquine. So don't you think everywhere primaquine is the drug of choice to kill every stages of plasmodia? But here comes erythrocytic schizophrenia, all drugs except primaquine. Which drug is not, primaquine is not effective in which stage of malaria? That is erythrocytic schizophrenia, when it comes into RBC. So what is the treatment of malaria according to National Vector-Borne Disease Control Program guidelines? We have Vivex Endovil. For Vivex Endovil, we give chloroquine plus primaquine. Remember, you have to remember the doses. Doses you will remember from PSN. Okay. So chloroquine, it is given for clinical cure. Clinical cure means to kill erythrocytic schizophrenia. Primaquine, it is given as a radical cure and as a gametocidal drug. So primaquine, remember, chloroquine given for 3 days, primaquine given for 14 days. It is given for 14 days. But what about P. falciparum? P. falciparum is chloroquine resistant. In all states of India, we give artesunate with sulfadoxine, pyrimethamine combination. So it is given for 3 days, single dose on second day. But in northeastern state, we give Artem ether with lumefantrine. Artem ether with lumefantrine. With these drugs, we will add primaquine. Primaquine, single dose on second day. Why we give primaquine? Primaquine is given only as a gametocidal drug. Remember, here it is not given for radical cure because P. falciparum does not have hypnozoid state. So this question will come definitely. Whatever the point I have written, each and every point is very important for you. Okay? Now, traveler's prophylaxis, mefloquine or doxycycline. Mefloquine 250 milligram per week, doxycycline 100 milligram daily. Agreed? Complicated malaria or acute severe malaria, the drug of choice is IV artesunate, which is considered to be the overall drug of choice. If it is not available, you can give IV quinine in 5% dextrose. Why 5% dextrose? Because quinine carries a risk of causing hypoglycemia. Carries a risk of causing hypoglycemia. Now, Kala Azar, what are the drugs we have? Remember a mnemonic, Lampas. Lampas. LA for, so LA for liposomal amphotericin B. It is considered to be the drug of choice. Liposomal amphotericin B, it is considered to be the drug of choice. Miltefosine. Miltefosine is the only oral drug and it is considered to be the drug of choice for PKDL. PKDL stands for post-Kala-Azar dermal leishmaniasis, paromomycin, and lastly we have sodium stibogluconate. Sodium stibogluconate. Now, which drug is given for amebiasis, luminal stage? When it is at luminal stage, we can give paromomycin. We can give diloxanide furoate. For amoebic dysentery and amoebic liver abscess, the drug of choice is metronidazole. Or you can use any drug which ends with the word nidazole, but in amoebic liver abscess, we add chloroquine. In amoebic liver abscess, we add chloroquine. We add chloroquine. Now let's talk about TB first line drug HRZE. H for isoniazid, R for rifampicin, Z for pyrazinamide, E for ethambutol. Now can you tell me a reason why isoniazid and pyrazinamide, they are having different symbol? What is the reason for it? Because these two drugs are prodrugs. These two drugs are prodrug. They get converted into another active form inside the bacteria. Their name starts from H and Z. So isoniazid inside the TB bacteria, it gets converted into active form. And by active form, it inhibits mycolic acid synthesis. It inhibits mycolic acid synthesis. Now, there is an enzyme which converts isoniazid into active form, that is catalase peroxidase enzyme in TB bacteria, which converts isoniazid into active form. Side effect of isoniazid is INH. It causes insanity. Insanity means it can lead to hallucination. It can lead to memory loss. It is neurotoxic and it is hepatotoxic. Now to treat this insanity and neurotoxicity, the treatment we give is pyridoxine. Pyridoxine or vitamin B6. Very good. Then we have rifampicin. R for rifampicin. Rifampicin inhibit RNA polymerase enzyme. It inhibit RNA polymerase enzyme. Side effect of rifampicin, red or orange urine. Red or orange urine. It is also hepatotoxic, just like isoniazid. Now this RNA polymerase, what is the cause of resistance to rifampicin? There is a mutation in a gene known as RPOB gene. And this mutation we detect by a test known as CB-NAT test. We detect by a test. CB-NAT test is done to check rifampicin resistance. Pyrazinamide inhibit protein synthesis, P for pyrazinamide. And its side effect is most hepatotoxic drug. And maximum risk of causing gout. Maximum risk of causing gout. Ethambutol. It is the only bacteriostatic drug. It is the only bacteriostatic drug we have. And ethambutol, its main side effect comes in eyes. Its main side effect comes in eyes. It can lead to optic neuritis and it can lead to red, green color blindness. It can lead to red, green color blindness. Okay. Now let's talk about TB in liver disease. So remember, most hepatotoxic drugs are pyrazinamide, followed by isoniazid, followed by rifampicin. So if TB occurs in, stop them and start SLE. This was a question of last year. SLE, these drugs are safe in liver disease patient. We give streptomycin, levofloxacin, and ethambutol. For TB in liver disease, stop pyrazinamide, rifampicin, and isoniazid. Now, TB in gout patient, maximum risk of hyperuricemia is by pyrazinamide again and E for ethambutol. But do you think gout is a dangerous condition? No. Do not stop them. Do not stop them. Just add allopurinol. To decrease uric acid level, just add allopurinol. TB in HIV patient, remember, first treat TB. So give anti-tubercular therapy and after a gap of 2 weeks, treat HIV. Start ART. Sir, why there is a gap of 2 weeks? We prevent the gap to prevent a syndrome known as iris syndrome. Why we give this gap? To prevent iris syndrome. Iris syndrome is when you will give HIV drug first, the immunity improves. It can lead to immune reconstitution syndrome. And immune reconstitution syndrome will happen, immunity will improve, and this immunity will suddenly kill TB bacteria, which can lead to rashes, hypotension, organ damage. So first give TB, second, then we give ART, and there is a problem with the drug rifampicin. Rifampicin is a CYP enzyme inducer. It increases the degradation of HIV drugs. It increases the degradation of HIV drug. Let's take an example. Dolutegravir. Dolutegravir. Dolutegravir is a drug for HIV. Question came. So what you will do with the dolutegravir? दौलत वाले ड्रग से क्या करोगे? If you are giving with rifampicin, dolutegravir की डोज हमें क्या करनी है? dolutegravir की जो डोज है हमें डबल कर देनी है. Double the dose of dolutegravir if you are giving along with rifampicin. Agreed? Double the dose of dolutegravir. Now second line drug for TB. First is Bell. Remember Bell. ये most effective drug है MDR TB के लिए. They are the most effective drug for MDR TB. The very important drug is bidaculin. तो बेटा bidaculin में बेड वर्ड आ रहा है ना, बेड वर्ड आ रहा है. जब आप बेड पे होते हो, when you are lying on bed, do you apply energy? Yes, if you are alone, you will not apply energy. Yes, if you are with someone, you will have to spend a lot of energy. So bidaculin decrease energy production. How it will decrease energy production? It inhibits mycobacterial ATP synthase enzyme. Agreed? So how we can remember? Bidaculin. BED, bed word comes, then ATP come, then Q word is coming. Side effect of bidaculin is QT prolongation. Side effect of bidaculin is QT prolongation. Clofazimine, given for TB, given for leprosy. Side effect of clofazimine is clofazimine was a coloring dye. It causes skin hyperpigmentation. Because it was a coloring dye, it causes skin hyperpigmentation. Cycloserine, side effect CNS. It causes CNS psychosis. Then we have Delamanid. Agreed? Then we have Pretomanid. You can see manid word is coming. Manid word is coming. Why manid word is coming? How you can remember? They inhibit mycolic acid synthesis. So mycolic acid is MA, mycolic acid inhibitor. Mycolic acid inhibitor. Now दिलामेनिड दिल वाला ड्रग है, तो दिल पे क्या होगा? QT प्रोलोंगेशन होगा. दिल पे बेटा क्या होगा? QT प्रोलोंगेशन होगा. Then we have ethionamide. ethionamide में ETH वर्ड आ रहा है, तो ethionamide इरेक्टाइल डिस्फंक्शन. It causes thyroid problem. Thyroid means it can lead to hypothyroid goiter, and it is hepatotoxic. Then we have thioacetazone. HI word aa raha hai. It is contraindicated in HIV patient, and thioacetazone is also a bacteriostatic drug. एक इथैम्ब्यूटॉल बताया था, दूसरा thioacetazone bacteriostatic drug. रिमेंबर दिस पार्ट, इनमें से बहुत सवाल आते हैं. फाइन. So what is MDR-TB? MDR-TB stands for resistance to H plus R. Isoniazid and rifampicin resistance is known as MDR-TB. What is pre-extensively drug resistant TB? It is MDR plus levoflox or moxiflox resistance. Levoflox or moxiflox resistance plus MDR. Then we have XDR-TB, extensively drug resistant TB. It is MDR plus Bell resistance. Bell stands for bedaquiline, linezolid, and levoflox, moxiflox resistant. Levoflox and moxiflox resistant. Now at today's time, what is the treatment of RR-TB, rifampicin resistant TB, MDR-TB एंड XDR-TB? आज की डेट में MDR, XDR और रिफेम्पिसिन रेजिस्टेंट TB का ट्रीटमेंट है B-PAL-M रेजिमेन फॉर 6 months. Agreed? B for bedaquiline. Last year question, Pretomanid, it is given for RR-TB, MDR-TB, XDR-TB. Yes. Then we have linezolid and moxifloxacin. Moxifloxacin, B-PAL-M regimen. Now tell me the answer of this question. You already know. एक पेशेंट है MDR-TB का, लो लेवल ऑफ T3 and T4. Agreed? That means patient is suffering from hypothyroidism. Which drug causes hypothyroidism? The drug which causes hypothyroidism was ethionamide. Next question. Which of the following anti-tubercular drug is not bactericidal? तो कौन सा ड्रग बैक्टीरियोस्टेटिक है? एक है थायोएसिटाजोन, दूसरा हमें याद रखना है इथैम्ब्यूटॉल. दे आर बैक्टीरियोस्टेटिक ड्रग. नेक्स्ट क्वेश्चन, लेप्रेसी. बेटा ट्रीटमेंट ऑफ डायग्नोसिस ऑफ लेप्रेसी नाउ हैज बीन चेंज्ड फ्रॉम 1st of April. Now the guidelines of leprosy has been changed. Let me tell you, leprosy skin lesion, it is divided into paucibacillary and multibacillary. If there is hypopigmented macule 1 to 5, we call it as paucibacillary. Don't write this part. 0 or 1 nerve involvement was paucibacillary. Now this has been changed. This has been changed. It is now 0 or no nerve involvement is. No nerve involvement is paucibacillary. If there is more than 1 nerve involvement, it is now considered to be the multibacillary. In earlier, 1 month before, if 1 nerve was involved, we were calling as paucibacillary. But now, even if 1 nerve is involved, we call the patient as multibacillary. Okay, beta? So we give 3 drugs RDC for 6 months. In multibacillary, we give RDC for 12 months. So treatment is 6 month and 12 month. I hope you know what is RDC, rifampicin, dapsone and clofazimine. So I hope this question will come. It has now been changed. So remember, ये बात अब change हो चुकी है. आपको पता होनी चाहिए. It is a potential question which will be asked. Now, which of the following anti-leprosy drug causes skin hyperpigmentation? We just discussed. Clofazimine, previous year question. Which of the following anti-leprosy drug is given in dermatitis herpetiformis? Dapsone is given. Now, what is the drug of choice for lepra reaction? Lepra reaction is hypersensitivity to leprosy drug. So, the drug of choice is prednisolone. But remember, in prednisolone resistant cases of type 2 lepra reaction, then we add a drug thalidomide. So remember, thalidomide 2 में दिया जाता है type 2 lepra reaction, which is also known as ENL, erythema nodosum leprosum. erythema nodosum leprosum में हम thalidomide भी ऐड कर देते हैं. Herpes virus, HSV1, HSV2, the drug of choice is acyclovir. Agreed? From acyclovir we made other drug pencyclovir, femicyclovir. But acyclovir is not effective in cytomegalovirus. Here the drug of choice is ganciclovir. So ganciclovir is the drug of choice in cytomegalovirus. Ganciclovir. From ganciclovir we made valganciclovir. Now in acyclovir and ganciclovir resistant cases, you can give foscarnet. You can also give cidofovir. You can also give cidofovir. Now remember, a new drug for CMV is fomivircine. Fomivircine. A new drug for CMV is fomivircine. Now in Bell's palsy, where there is facial nerve damage, my question from you student is, what is more important? When the facial nerve is getting damaged, what is more important? To kill herpes virus is more important, or to protect the nerve? What is more important? In Bell's palsy, tell me, to protect the nerve or control inflammation is more important, or to kill virus is more important? What do you think should be the answer? Remember, first we have to protect the nerve. Otherwise, nerve permanent damage. The drug of choice for Bell's palsy is prednisolone. Yes, you can add acyclovir like drugs, but remember the drug of choice is, remember always and always, prednisolone. So swine flu, the treatment is neuraminidase inhibitor. So neuraminidase inhibitor, they will end with the word mivir. Mivir, like oseltamivir, zanamivir. Oseltamivir, oral. Zanamivir, nasal spray, MCQ. Respiratory papillomatosis, cidofovir. Cidofovir, respiratory papillomatosis. HBV, hepatitis B virus, tenofovir or entecavir. Both are first line drugs for hepatitis B virus. Tenofovir, entecavir. Now let's talk about certain monoclonal antibodies against microbe. Palivizumab, VI word is coming. It is against a virus. Which virus? It is against RSV virus, respiratory syncytial virus. Ibalizumab, Ibali, क्या आप बता सकते हो where Bali is located? सर बाली कहाँ पे located है? बाली कहाँ पे located है? बाली कहाँ located है? बाली इंडोनेशिया में है. तो जस्ट इमेजिन यू वेंट टू इंडोनेशिया, बाली, यू हैड लॉट ऑफ फन, और वहां पे आपको क्या हो गया? गलती से HIV हो गया. तो विच ड्रग इज गिवन इन HIV? इबालीजुमैब, बाली वाला, इट ब्लॉक्स CD4. इबालीजुमैब ब्लॉक्स CD4. रेक्सीबैक्यूमैब, बैक मीन्स इट इज अ बैक्टीरिया. AX word is coming. It is against which bacteria? Anthrax bacteria. It is against which bacteria? Anthrax bacteria. Fine. Now let's talk about HIV. Which is the drug of choice for HIV nowadays? That is TLD. Tenofovir, lamivudine, dolutegravir. Now what is the main side effect of tenofovir? Side effect of tenofovir is Fanconi syndrome. In Fanconi syndrome, there is phosphate loss. The patient suffer from osteomalacia or rickets. That is why tenofovir, it is contraindicated in children less than 10 years of age. So tenofovir, it is contraindicated in children less than 10 years of age. Tenofovir 10 साल से 10 word is coming. So in children less than 10 years of age, this tenofovir, it is replaced by zidovudine. It is replaced by zidovudine. In children less than 10 years of age, zidovudine side effect is anemia because it causes bone marrow suppression. Now, D stand for dolutegravir, and dolutegravir main side effect is it causes Stevens-Johnson syndrome. That is why it is contraindicated in children less than 6 years of the age. It is contraindicated. तो फिर क्या करें? In children less than 6 years of age, we give ZLLR. LR stand for lopinavir, ritonavir combination. So ritonavir, lopinavir, remember they are protease inhibitor, and their main side effect is they produce lipodystrophy syndrome. Lipodystrophy syndrome means diabetes mellitus, obesity will happen. So their side effect is lipodystrophy syndrome. Post-exposure prophylaxis of HIV, we give TLD 3 drugs for 1 month or 28 days. For 1 month or 28 days. Now, neonatal prophylaxis from HIV positive mother is given for how many weeks? Last year's question of your NEET exam. The answer is 6 weeks. 6 weeks is the answer. So let's talk about neonatal prophylaxis in newborn, which is born from HIV positive mother, low risk infant. The drug of choice in neonate is, neonate में drug of choice क्या होगा? Nevirapine. For how many weeks? 6 weeks. जैसे ही न्यूबॉर्न पैदा हुआ 6 weeks तक नेविरापीन दो. हाई रिस्क इन्फेंट है, give नेविरापीन with zidovudine combination for 6 weeks. So this is prophylaxis of newborn in HIV positive mother. Agreed? So overall drug of choice in neonate. Neonate में बेटा कौन सा drug of choice होता है? Neonate में overall drug of choice होता है ताकि HIV ना हो. From mother, neonate we give nevirapine. In neonate we give nevirapine. Next we have common drug for hepatitis B virus, hepatitis C virus. Remember interferon alpha. Any student who tell me interferon beta हम कहाँ use कर रहे थे? Interferon beta were given in multiple sclerosis. Interferon alpha कहाँ use होता है? Alpha is given in, alpha means A, it is given in B and C virus, ABC. Common drug for hepatitis B virus and HIV virus, tenofovir and lamivudine. Common drug for hepatitis C virus and respiratory syncytial virus, ribavirin. So this finishes our antimicrobial. Now one small topic is left and I don't want to repeat it again. The reason is you can see this topic from previous LRR because there is no new drug which has been approved. So previous LRR, you can see anti-cancer drug. It is just for 15 and 20 minutes I have taken in that previous LRR. And you can see that previous LLR anti-cancer drug, we are finished with full pharmacology. Okay. I will be taking anti-cancer again in LRR of INI-CET when it will be going to happen in future. Okay. Because right now no new drugs have been approved. So this is all you have to remember. I hope you enjoyed the session like I have done. A lot of energy. I really want to appreciate you all students. Even for 1 second, I haven't seen the response was not there. Even if I was asking something from past 3.5 hours, students are so attentive and I really appreciate your commitment. And okay, really am feeling very proud of you. The amount of hard work you students are giving. जितना hard work आप कर रहे हो, definitely no one can stop you. Just keep on revising everything. Okay? Just keep on revising. I know I went a little bit fast because your time was precious. So I was not stopping in between because on YouTube, this video will remain there and you can see each and every point, each and every trick I have told you. You can read them again. Okay. So anti-cancer drug, just see from the previous LRR, I have there just for 15-20 minutes more. So I have discussed all the new drugs. Just see that section mainly for INI-CET. I don't think much will come from NEET exam. Okay. Yes, I'm sharing the PDF with PrepLadder team. I will notify them again, probably. Okay. No, I don't think there is a need of doing. You can just see the previous LRR from previous one. Sangita ji, this is, I have told you, na, involuntarily painful, painless orofacial movement. She is suffering from tardive dyskinesia. Give tetrabenazine, valbenazine. No. I don't think, I don't think that you should require any fresh LRR, but that is a uh, decision of all the other faculties we will take together. We all faculties will take a decision whether there is a need to do it, then we will do it. Okay. Otherwise, I don't think. Okay. So if you have any doubt, beta, you can ask me. If you have any doubt, you can ask any of your question. I'll be very happy to answer. Yes, Karishma, if you will use this for FMG, I think it is more for FMG. So yes, you can definitely see this session. All the questions of FMG will be taken care of in great detail. Don't worry about that. Yes, you can use this session. Okay. Any other doubt or any other question you have in your mind? So let me tell you this, a very important कोट ऑफ विजडम. रिमेंबर, आप बच्चों का कंपटीशन जो है किसी और से नहीं है. यू डोंट हैव एनी कंपटीशन विद एनी अदर ह्यूमन बीइंग. द ओनली कंपटीशन यू हैव इज द पर्सन विच यू फेस, विच यू सी इन मिरर. दैट मीन्स आपका अपने आप से कंपटीशन. मेक श्योर दैट यू अपग्रेड yourself every day, bit by bit, slowly and slowly. You improve yourself each and every day. Be consistent in reading. And if you are consistent and disciplined, remember it is more important than motivation. Motivation is not important. What is important is discipline in life. If you are disciplined, you will always remain humble and you will always remain motivated. Agreed? So, थोड़ा थोड़ा पढ़ते रहना, रुकना मत. चाहे एक दिन नहीं पढ़ पा रहे, try to read half an hour, 1 hour, but don't stop reading. एवरी डे इज इंपॉर्टेंट. जिस दिन ज्यादा टाइम मिल जाए ज्यादा पढ़ लो, जिस दिन कम टाइम मिल रहा है कम पढ़ लो, पर पढ़ना जरूर है. बी कंसिस्टेंट, बी डिसिप्लिन्ड. ट्राई टू इंटीग्रेट ऑल सब्जेक्ट लाइक आई हैव इंटीग्रेटेड. दैट विल हेल्प यू टू सॉल्व क्वेश्चन. So because these questions which I've told you in pharma, they will be asked in PSM also, they will be asked in surgery, medicine, obs gynae as well. Because everywhere we ultimately have to use drugs. Pharma is all about drugs. So try to integrate these systems with other subjects as well, so that it becomes easier for you to understand the disease. Beta, about GT scores, I want to tell you one thing. When you will start doing GTs, initially your score will be very low. Because from there you will understand and you will come to know that where you are lacking. Don't be afraid of that if your scores are very low in GT. Solving a question, getting a poor marks in GT is not a problem. What you have to do after you are done with GT, spare one day and analyze that grand test you have given. When you will analyze that grand test, you will able to understand what mistakes you have done, what all things you don't know. Only then you will able to overcome your drawbacks and weaknesses. If you keep on doing like this, at least try to give 2 or 3 GTs in a month. If you will do consistently this thing for, let's say, 5-6 months, your score will drastically improve. फर्स्ट जीटी सबका बुरा होगा, जो लास्ट जीटी होगा आपका बेस्ट होगा. यू विल ऑल्सो स्कोर, आई वुड से बहुत अच्छे मार्क्स आएंगे आपके. एग्री? तो रिमेंबर लाइक दिस, पहले दिन में अच्छा नहीं होगा जीटी, किसी का भी नहीं होगा. इम्पॉसिबल, बियॉन्ड ह्यूमन कैपेबिलिटी. और जो भी स्कोर आए जीटी पे किसी से शेयर मत करो. कीप योर स्कोर्स विद टू योरसेल्फ. इफ यू विल शेयर योर स्कोर्स, then you will come under anxiety. So you should know your drawbacks, you should know your strong points also. Be calm and composed, ऐसे ही रखना. ठीक है? कोई डाउट आए, if anything you are not able to understand conceptual wise, factual wise, you can ask me directly. You can ask me on PrepLadder channel. You can directly ask me through Instagram, Facebook. I'll be very happy to answer it. Okay? Use this LRR as a base now, and try to build your empire over this base, or try to build your building over this base. This at least you have to remember. And this will solve more than 80-90% of your question which will be coming in your exam. Okay? Okay? So with this good note, I congratulate to all of you. Number of correct stuck in GT, don't worry. If even you're stuck in GT, don't worry. A time will come. Just keep on giving 2-3 more GTs. Your score will definitely improve. After every GT, analyze your bad scores, analyze your wrong question, analyze other options, why they were not the correct answer. Initially give some efforts on GT, later on the things will become very smooth for you. Definitely your score, GT score will improve, don't worry. Okay? Definitely it will improve. I have strong confidence in all of you people. If you keep on doing, remember beta, always remember one thing, there is no shortcuts in life. There is no secret formula or secret magical portion which you will drink and something will improve. No, there is nothing shortcut. There are no geniuses. There are no magic. Geniuses are made by hard work. Genius people, they are made. They themselves become by consistently doing hard work. Then you will have a very good score. One day you cannot do everything because it is human, beyond human capability. करते रहो, हो जाएगा. ठीक है? बाकी ऊपर वाला बैठा है, विश्वास रखो, सब होगा. ठीक है? Don't worry about that. Best wishes. Enjoy your day. Thank you very much. I'll share the PDF. Thank you.